We are live now, sir.
Okay. So, good evening, everyone. This is Rishikesh Chaudhary. I am the Group Product Manager at Universal NutriScience. And it's my pleasure to welcome you all to this Inspire webinar series. It's a collaborative academic initiative by MPSR and UNS. And special thanks to our Program Director, Dr. Archana Basir, Madam, MPSR specifically, and all the other dignitaries who are present here for their constant support in making this event possible, right? So at UNS, we usually take pride for being one of the India's fastest growing nutraceutical companies. This year, we are especially celebrating our significant milestone of 25 years for our brand CoQ300, which is India's first coenzyme Q10 brand, and also our leadership in terms of gynae, the Primoza in EPO market. Also, our blockbuster launch that is UNS D3, which further reflects our continued trust and support to the fraternity. At UNS, we usually believe knowledge sharing is really pivotal and crucial for better healthcare, and Inspire is a step forward to that commitment. So, thank you once again for joining us. Without a further ado, I now hand over this session to Dr. Shruti to take this session forward for today's important topic that is poor ovarian responder. So, Dr. Shruti, over to you.
Thank you so much, Rishikesh sir. Good evening to all the esteemed faculty members present with us here today. My name is Dr. Shruti. I am from the Medical Affairs team of Universal NutriScience. I would like you to welcome to the Inspire series, which is in association with MPSR. For this time, the topic is poor ovarian responders, and this obviously wouldn't have been possible without Dr. Archana Basir ma'am, and also the support and guidance of Dr. Kumari Ditya ma'am, who's the MOC, and our conveners, Dr. Garima Sharma ma'am, Dr. Amrita Tandon ma'am, and Dr. Aditi Tandon ma'am. So Dr. Kumari Ditya ma'am is an assistant professor at Government Medical College, Satna. She has also done her fellowship in minimal access surgery and urogynecology and has several publications in her name, including 7 national publications and 1 editorial article. Dr. Garima Sharma ma'am, who is the medical director at Eva Care Plus Fertility and Complete Women Healthcare Center, Mumbai. She is the managing committee member for ISAR as well as the managing council committee member of Maharashtra State Chapter of ISAR. She has several accolades to her name and has also received the gold medal in the Fellow Reproductive of Medicine at Sir Gangaram Hospital, New Delhi. Dr. Amrita Tandon ma'am, she's a fertility IVF consultant and gynae endoscopic surgeon at Dr. Sudha Tandon Fertility, IVF, Endoscopy and Maternity Center, Chembur and Vashi. She's a trainer at IMMAST. She is a youth council member for both IAGE as well as MONGS. She has also done various fellowships nationally and internationally. She has won several awards and has several publications to her name as well. Dr. Aditi Tandon Man is an obstetrician gynecologist, laparoscopic surgeon, a fertility specialist, a cosmetic gynecologist. She is currently practicing at Endoscopy and Maternity Center at Chembur, Mumbai, Vashi, Navi Mumbai, at Surya Hospital, Santa Cruz. She has also done a fellowship in ART and advanced minimally invasive laparoscopic surgery and so on. She also has several awards to her name. And with this, I would like to hand over to Dr. Aditi ma'am, Dr. Amrita ma'am, and Dr. Ditya ma'am.
Thank you, Shruti, for that kind introduction. A very warm welcome to all for the third webinar of the Inspire series, which is the brainchild of Dr. Archana Baser. This is under the aegis of MPSR and supported by UNS. Today's webinar is centered around discussing poor ovarian responders. We have some interesting talks and a panel lined up. And to begin, it is indeed an honor for me to introduce our program director, Dr. Archana Baser. She needs absolutely no introduction. We all know her as someone who's extremely enthusiastic and dynamic. And to formally introduce her, she is contesting for the Foxy presidential candidate in the election year 2026. She is a consultant obstetrician and gynecologist at Akash Hospital, Indore. She has been vice president Foxy 2020. Presently, she is chairperson MP ISAR, a fellow representative of AICC RCOG West Zone. Joint Secretary is SPART. She's been the organizing secretary for AICOG 2021 Indore. Her past positions include chairperson for Foxy Imaging Science Committee, Organizing Secretary ESAR in 2016, Managing Committee Member ESAR 2018 to 2020, IAGE and ICOG, and Imaging Science Member of EOFOG, and Imaging Science Committee Chair of SAFOG 2020 to 2023. I'd also like to take this opportunity to congratulate her on becoming a grandmom, although she absolutely does not look like one. Requesting Archana Vaser ma'am to please take the dais. Welcome, ma'am.
Thank you, Aditi. Thank you for the kind introduction and being with me for throughout the series. So I'm at the outset, I'm really, really grateful to all my coordinators, Garima Sharma, Aditi, Amrita, and Ditya for really bringing all the faculties together and corresponding with them and making this possible. And today's topic, as Aditi has said, that it is poor ovarian, poor responders. I think we all are worried about poor response in IVF or even in the non-IVF cycles. And today we have the doyens of infertility management in India and internationally recognized Dr. Nandita Palshetkar is our chief guest for this series, and Dr. Kirnakoti is Kurtakoti for as a guest of honor. So I would like to introduce first Dr. Nandita Palshetkar on and invite her on the podium to give us advice, blessings, and updates, and any inputs on this topic. Nandita Palshetkar, I know her as a great human being, a good friend. She is past Foxy president. She is eminent IVF specialist with over 30 years of experience and medical director of Bloom IVF. She has 10 centers all over the India. She is pioneer in India in latest techniques, technologies, and delivered so many lectures, orations. I think she, if I keep reading her CV, it will be there is so many things. I think she might not have put it in her CV as well, just to make it short. So Nandita, I think this is a phenomenal CV you have. Lots of awards you have received, and the above all, Nandita is always there, and she never forgets to wear her smile ever. Over to you, Nandita.
Thank you, Archana. Thank you so much for inviting me. It's a real honor to be the chief guest of the function. And especially my dear friend from amongst Kiran Kuttakoti is here. We really enjoyed our presidencies together, and it's been an amazing time. And Archana, first of all the best. I think I know you for the past 20, 25 years, and I have seen how diligently you work, how you do how everything is carried out. So all the best in your future journey. And UNS is somebody very close to my heart. You know, Poor Ovarian Reserve is my pet topic, and I think there is so much we can do for the girls, and we have seen an increasing incidence in poor ovarian reserve, and there are many ways in which we can combat it. And I think awareness is most important, Archana. I think, people come to me and they say, oh, we've done so much treatment and their AMH has been identified much earlier. But people say, oh, I've had patients who are pregnant with this zero point 0.6 AMH. You don't need to worry, you're young. I think what we need to understand is that 30% of the people with low AMH will conceive naturally, in the general population. But 60 to 70% suffer from some form of infertility and they reach our clinic. And that is what we have to spread the awareness that this is important. This is a silent pandemic which is hitting women and they need to be aware of it. So I think I'm really happy that you have taken this topic and are, talking about it. And there are so many therapies. I mean, besides the adjuvants like PO and Q10, etc., I think even the ovarian rejuvenation techniques can really be discussed. And I'm sure it's going to be fantastic. Uh, so all the best, Archana, for your future in Foxy. And also, I think I can see Brijbala here and MP Isar. Thank you for inviting me. And my girls from Bombay, I think Amrita, Garima, and who else is there?
Aditi.
Aditi. Okay, sorry. Hi. So that's really great, amazing, and thank you for inviting me on.
Thank you, Nandita. Thank you. I think the very important point which you brought out, that we really need to increase awareness, not amongst the patient, amongst our own fraternity, that low AMH is a pandemic. It isn't a pandemic, and we really need to not like, I mean, you have to do counseling, but you cannot say that, well, I have this patient with a low AMH pregnant. Yes, that's true. But again, this is also true that with the low AMH, you really need to start treatment early as well. And then you have to really talk to them, take them through this low AMH situation. So very well said. So thank you very much, Nandita, for gracing the occasion. And
Archana, please touch on egg freezing also for the girls. Please. That's something very important which is really required. So I shall now sign out. I think I
thank
will
you.
probably give a lecture over here. Okay.
Thank you. Thank you so much.
Thank you,
Nandita.
ma'am. Thank you for
Thank
guessing.
you.
So
Thank you, ma'am.
I mean, we have all the panelists and panel moderators and galaxy of people here. I would like to invite now our guest of honor, Dr. Kiran here. Can I have the Dr. Kiran CV? I think Dr. Kiran also I know for so many years and is again a great friend and a great human being and very friendly person. He is currently president of All Maharashtra Obstetrician and Gynecologists Association or Society, founder president of Maharashtra College of Obstetrician and Gynecologists, and founder president of EMOX Teacher Association. He has served Foxy in various capacities, chairperson MTP committee, and just few lines, Kiran, about you, that he has so many awards, publications, and he has given over 150 talks at national and international conferences. We are really blessed to have you on this podium, Kiran. Over to you for your words of wisdom.
Thank you. Thank you so much for those kind words at the outset. A warm greeting and from amongst to all of you. Our chief guest, Dr. Nandita, our post-director, Dr. Archana, and of course, Tandon sisters, as we fondly call them, Aditi and Amrita, Garima and everyone, Dr. Brijbala and everyone. And of course, really, you have got a great initiative because, ISAR is doing a lot of things as far as the ovarian awareness is concerned. Now, in Amos, we have launched a program called as Me Manasvi, which makes the general public aware of their ovarian reserve. So, but I think with this particular series of yours, you are going to make the gynecologists and obstetricians aware of the low ovarian reserve or low AMH issue. So, I think that's a very nice initiative and backed by UNS. I agree. UNS is the fastest growing nutraceutical companies. We had their presence a few days back at the BreastCon conference also with the Pink Palm initiative. So thank you, UNS, also for that initiative. But Dr. Archana, you really have brought the cream de la cream, what we can say, of infertility. So would love to listen to you as well as to Kundan and of course my friend Tejas and Dr. Rajkumar moderating the panel. Also, best wishes to you. I didn't know you were a Guinness Book holder. Which reflects in your CV. So I think that should be made more prominent sometime. Anyway, so thank you so much for that. And really, my best wishes to you in your future endeavors, of course, in ISAR and Foxy. And let us get on with the program and hope to see you soon at the Solapur Zonal Conference also. Thank you so much.
Thank you, Kiran, for your kind words. And please stay with us for this webinar. And we really want to take different topics and percolate it in amongst our fraternity for awareness, increasing awareness and updates, so that ultimate aim is to benefit our women who are reaching to us. So over to you, coordinators and conveners, for further taking up the webinar.
Thank you so much, ma'am. Now I'm going to start this webinar. I'm really honored to be on this floor because of Dr. Archana, ma'am. And really thank you to Dr. Garima, ma'am, and Amrita, ma'am, and Dr. Aditi to include me in the CME. Now I'm going to introduce today chairperson, Dr. Brijwala Tiwari, ma'am. Kindly Yeah, please, thank you. Um, Dr. Bijwala Tiwari, ma'am, she is a consultant and gynecologist and infertility specialist and credentialed menopause practitioner, managing director in Life Care Hospital, Sanctuary Infertility and Test Tube Baby Center in Indore. She is chairperson in Foxy Environmental Health Committee 2025 to 27 and secretary in MPSR 2025 to 2027. And she is also past president of Indore OBGY Society 2022 to
Thank you, Dr.
2023.
Divya. Thank you so much for kind introduction.
Thank you so
so
much,
much.
ma'am. Kindly display Dr. Meenu. Good evening, ma'am. Dr. Meenu Handa, ma'am. She is MSDND FICOC FRM. She has done fellowship in reproductive medicine IVF and gynecologist and fertility specialist in Cloud9 Hospital. She is a clinical and director and unit head in Cloud9 Hospital, Gurugram, and senior fertility consultant in Cloud9 Hospital, an ex-unit head in Fortis IVF Center in Gurugram, and North Zone Coordinator in Fox's Endocrinology Committee, and Secretary Haryana Ishar. She has also had many appreciation in SR Aspire and SR Arjun and Art Icon Award 2021. She has done also fellowship in reproductive medicine FRM from Tamil Nadu University and several publications in reputable international and Indian journals, and author of many chapters in various books. And she's guest lecturer at various national conferences. Thank you so much, ma'am. I would like Dr. Rini Singla, ma'am. She has MBBS, DGO, and FICUG, MRCOG in UK, diploma in reproductive medicine in Kiel, Germany, and then fellowship in cosmetic gynecology in American Aesthetic Association. She is medical director in Radiance IVF and Radiance Super Speciality Hospital, Mohali, Punjab, and president in Mohali Obsgyne Society, MOHOGS, and secretary in SR Chandigarh. She is empaneled faculty for Foxy ICOG certification course for IVF and endoscopy. She has invited as senior faculties in many conferences. She has been awarded and had many achievements with Rashtriya Swarnim Hindi Award 2019 and awarded in Best IVF Specialist Punjab International Healthcare in 2017 and Technician Education Minister Punjab awarded for excellence in IVF and laparoscopy 2024 in Punjab and awarded for excellence in IVF services 2025 by Punjab Health Minister Balbir Singh Ji and awarded for emerging leaders in IVF and reason by Indian Health Council Delhi. Thank you so much, ma'am. Now I would like to start the CME by the chairperson, our Dr. Archana Base, ma'am, to introduce and start the CME.
I think I'm being introduced, Ditya. So let me allow me to share my presentation.
Yes, ma'am. Thank you, ma'am.
Good evening, everyone. Let's begin with the topic. Controlled ovarian stimulation in protocols in women with the poor responders. I think when you talk about poor responders, there are certain things which are not still very clear. Poor responder, the definition also, they keep changing. And so we will be little bit looking at the definition of poor responders. Number two, there are two types of poor responders. One, poor responders, if you go by the Poseidon group, you know that they are who are going to be good responders and who are not going to be good responders. But sometimes you are taken by surprise. You have chosen your patient for a particular protocol, young women with good AMH, good antral follicle count, and you are using the similar gonadotropin which you are using for been using in your practice, but they don't respond. So if you look at the Poseidon group, you have young patient less than 35 years with adequate ovarian reserve parameters, and you know and with an unexpected poor or suboptimal ovarian response. This is subgroup 1A, less than 4 oocyte, and subgroup 1B, 4 to 9 oocyte retrieved. Poseidon group 2, older patient, more than 35 years with adequate reserves. Subgroup 2A, less than 4 oocytes, and subgroup 2B, 4 to 9 oocytes. And Poseidon group 3, young patients, less than 35 years with poor ovarian reserve, pre-stimulation parameters, enteral follicle count less than 5, AMH less than 1.2 nanogram per ml, and Poseidon group 4, older patients more than 35 years with poor ovarian reserve, pre-stimulation parameters, enteral follicle count less than 5, and AMH less than 1.2 nanogram. So let's look at the definition of poor responders. It ranges from less than 3 to less than 5 dominant follicles on the day of HCG administration, less than 3 to less than 5 retrieved oocyte. Peak E2 level is another criteria used. A peak E2 level of less than 300 to less than 500 picogram per ml proposed as being crucial for diagnosing poor response. An elevated day 3 FSH level ranging from more than 7 to more than 15 milli international unit per ml has been proposed as an additional criteria to determine poor ovarian responses. Now, how to diagnose? At what level of day 2 FSH would you identify a poor responder? I think there is a lot of controversies about it. Like there is more than 19 U per liter, 4%, 15 to 19, 12 to 15, or 10 to 12, or none of the above. Which factors you will check? But I think in practice we check less when we start our stimulation protocol. It has to be less than 10. That's the criteria. Now there is a problem in the definition of poor responder. So how to define, diagnose, and treat poor responders? Response from a worldwide survey of IVF clinics. There's a beautiful article in Reproductive Biomedicine online, and that is really a good article where you can find how to define. And ASHRAE consensus on the definition of poor response, if you look to ovarian stimulation for in vitro fertilization, the Bologna criteria, this is 2 out of 3 criteria should be there. Advanced maternal age or any other risk factors for poor ovarian response, a previous poor ovarian response, or an abnormal ovarian reserve test. These are the 2 out of 3 criteria, and then you can take that they are poor ovarian responder. There's a heterogeneous category generally defined as less than 4 oocyte retrieved with IVF, that is called as poor response. But less than 4 follicles, maybe in 41 years old, 34 years old, 35 years old, undergoing mild stimulation, they are not equivalent situation, and each has a different prognosis for successful pregnancy. So you cannot have just one criteria that less than 4 follicles and which does not apply to all age groups. So you have to really have individualization of the definition of even the poor ovarian response. So CD7 FSH above 22 international unit per liter associated with poor response regardless of the daily dose of FSH injected. Increasing the dose of FSH is not helpful since the present FSH dose is not fully utilized. Who are the low responders? There is no difference in FSH receptor expression compared with normal responder. Hyper responder are the one which we know are the PCO women, hyper expression of FSH receptors, and high serum and FF androgens in these women. So this is a risk of low response. This is a graph which is showing that low risk of low response in women where you have a low enteral follicle count. So you know the prediction. So when a patient comes to you, you do a counseling like your enteral follicle count is less, and we are likelihood of getting the number of follicles, fertilizable follicle is going to be less. So that is going to be helpful. Now, another thing is women's age, when to stop. Like, will you stop at 40? Will you stop at 42? Will you stop at 45? I think this is again individualized, that some women at 40 might have good AMH, some women at 25 may not have good AMH. As we were talking in the beginning, that there is an epidemic of low AMH and low ovarian reserve. So age is one criteria, and which is very important criteria. But now when you are looking only at the age, you cannot say that this person is going to have a poor response or a younger woman is going to have an adequate response, that we know. But many a times younger women may not have the good response either. So I'm not taking into this all. So what are the, what you can use when you find that the response is poor? Are you going to use aromatase inhibitor? Are you going to use transdermal testosterone or DHEA? So let's look into one, or you are going to use the extended letrozole. So the pregnancy rate per cycle was not different between the different groups which received the letrozole in addition to FSH and those who did not. So the number of COCs retrieved was not significantly different between these two groups. So now, can you use different groups of medication? Essential substrate for production of estrogen via the two-cell, two-gonadotrophin therapy or model for estrogen biosynthesis. Androgens have some synergistic effect with FSH and folliculogenesis, and dihydrotestosterone or testosterone augments follicular FSH receptor expression in granulosa cell. It promotes initiation of primordial follicle growth and increases the number of growing pre-antral follicle. So growth and increases the number of growing pre-antral follicle and small antral follicles. So this is a very busy slide. I think let's not go into that. So transdermal testosterone and letroz both significantly. Can you use them? Decreased dose of gonadotropin needed for stimulation. If you use both, decrease the number of days to HCG trigger. It seems also to increase the live birth rate. So, when you are not getting response with your standard gonadotropin, you know that the response, this is a poor responder. You are going to try and add different medications to make it happen. So this is either you can use combination of a transdermal testosterone and letrozole, both. And then DHEA treatment may create PCO-like characteristic in aging ovaries. So transient increase in IGF-1 in patients undergoing exogenous gonadotrophin, ovulation induction after pre-treatment for only 8 weeks of DHEA. So suppose if your patient has not responded in that cycle, you can give a break, start them on DHEA for 8 weeks, and then you can start the stimulation again. So this is a comparison of result of IVF before and after treatment with DHEA. This is the one study where they have shown that there is a little increase in the number of follicles and embryos and the blastomeres. So poor responders and androgen, this is a very adjuvant treatment, still haven't found what I'm looking for. So these are the different RCTs on women with a poor ovarian response. That is group A patient, DHEAs, group B patient, control and long agonist protocol. Retrospective definition of poor ovarian responses, less than 5 COC retrieved in a previous cycle. 75 milligram of DHEA orally once a day, at least 6 weeks before starting the first cycle of ovulation induction and 2 cycles of IVF, so that you can use. And then there are different variables were used in the study, like clinical pregnancy rate and live birth rate. So conclusion, there is no improvement on probability of pregnancy when you combine with a DHEAs, but yes, you can use it and you can try and see it out. So different regimes are there, different studies are there. In women with poor response, there are studies, like they had a 96 patient in this study of clean cut, and what protocol they used was high fixed dose of gonadotropin versus a decremental dose in short mini dose GnRH agonist protocol. And outcome was ongoing pregnancy rate. And then conclusion of this study again was a high fixed dose gonadotropin regime does not improve the pregnancy rate in poor responder patients. So poor responder patients remains difficult and challenging. You may use higher doses of gonadotropins, you may add on various things, but still I think there's a lot of research and a lot of work is needed to look in this group of women who are not responding very well to our routine gonadotropins, because there are a lot of cycle cancellation in these women because they are not responding to your standard treatment. Now, there was one randomized control trial which compared natural cycle IVF versus short GnRH agonist FSH protocol and the poor responders, and clinical pregnancy rate per randomized patient was not significantly different. So in this protocol versus their standard protocol. Now, growth hormone role in ovarian steroidogenesis and follicular development. In mice lacking growth hormone receptors and growth hormone binding protein, follicular development is significantly reduced in response to gonadotropin stimulation. It increases the intra-ovarian production of IGF-1, which is considered to play an important role in ovarian function and stimulating follicular development, estrogen production, and ovarian maturation. So the background of growth hormone is growth hormone enhances gonadotropin effects on granulosa cells, and GHRF enhances gonadotropin-induced steroidogenesis, cyclical adenosine monosphere formation, cyclical AMP. So again, this is too busy a slide to go through. Then you have a no significant difference in pregnancy rates per started cycle were higher in patients stimulated with recombinant FSH compared with ultra FSH. So shorter duration of stimulation and lower dose of gonadotropins requires in the recombinant FSH group compared with UFSH group. Significantly more COCs were retrieved in patients stimulated with recombinant FSH compared with those stimulated with UFSH. So the difference is 7.2 versus 5.6, and difference 1.6, 95% confidential interval is P 0.1 to P 3.1. Now, there are again different studies where they have studied the different group of medication. So with the different number of patients, here in this study, 145 was the number of women and the enteral follicle count was less than 12, and there's no different significance in any parameters measured. So you might say that why we are talking about when there's no significant differences, but anyways, we have to keep trying the different modalities of treatment to improve our results. So systemic review and meta-analysis, transdermal testosterone pre-treatment for IVF in poor responders, increased clinical pregnancy rate and live birth rates. Insufficient data is available to support a beneficial role of DHEA, aromatase inhibitor, recombinant LH, and HCG. So combination of two stimulation in one menstrual cycle, what you say is nowadays it's becoming popular, and then again it goes down, that you start with dual stimulation in the same cycle, then you get reports from different groups that when it's not beneficial. So it is targeted for enteral follicle count in the follicular phase and luteal phase. So 2 chances of ovum pickup in a single menstrual cycle, which achieve more oocytes and viable embryos. But randomized control trials in poor responders are needed to evaluate the outcome. So that is the crux of the story. So this is how the double stimulation is done. Like you start with CC 25 milligram or Letros, and then you ovum pickup is done, and then again in the cycle, you mid luteal phase, you again do the ovum pickup in that cycle. So dual ovarian stimulation is a new very viable option for enhancing the oocyte yield when the time for assisted reproductive technology is limited, especially in the older women. So this is the follicular asynchrony, and I'm just going to go cycle cancellation and pregnancy after luteal estradiol priming in women defined as poor responder. This is again a very good study, a systematic review of meta-analysis. So there is again an insufficient evidence exists to recommend most of the treatment proposed to improve pregnancy rates in poor responders, intercycle variation of enteral follicle count, transdermal testosterone prior to ovarian stimulation, seems to significantly increase the live birth rate and reduces the dose of FSH required among poor responders. Because what happens in practice, when you're scanning on day 3, all counseling done, your all hormone estimations are done, and then you start stimulation and you don't you call them to be reassessed on day 5, you find that your gonadotropins have not worked. You start increasing the dose of you start pumping in more gonadotropins. So you really have to think about that whether this woman is a poor responder, and do I need to add on something more? So there is some evidence to suggest that addition of growth hormone as well as performing embryo transfer on day 2 versus day 3 and dual stimulation appear to improve the probability of pregnancy, and E2 priming improving outcome of by synchronization. So thank you very much. I think this is the Onam week going on. So wishing all a happy Onam. So thank you for patience listening.
Thank you, madam. It was very elaborate talk on ovarian stimulation in poor responders, and it is need of time because every day we are seeing one or other patient with whether they are young or they are elderly, but they are coming with low AMH, low AFC, and it was nice talk, ma'am. Thank you so much.
Thank you, Dr. Brajbala.
And my greetings to Kiran sir and Nandita madam for blessing MPSR chapter webinar, sir.
I can see Dr. Rajkumar here, Kundan here. I would say it's a challenging topic, to handle the poor responders. Over to any questions or over to conveners for the next talk?
Yeah, ma'am, I had a question. What is your personal favorite? What do you give in terms of adjuvant, or what protocol do you follow for ovarian stimulation for patients who are expected poor responders, say in a low AMH patient?
Actually, what we do, that's a very good question. I think this forum is for personal experience because research and articles we read, and then sometimes we do not get any conclusive answer what to do when there is a poor response. What you have to do, you have to counsel the patient, you have to ask them to wait, you have to prepare them for the future, like how you do when you plant a tree, prepare them. But we are not increasing our dose beyond 300 international unit of FSH, because pumping in more FSH or means more gonadotropin is not going to help. Sometime off the record, like we do start with this Ciscure or some kind. We call the patient on day 2. We assess them and we see that the size of the follicles is very small. We give a dose of antagonist for initial 3 days, 4 days, and then we start their stimulation, and we have had good results in successful growth of the follicles in the same cycle.
Okay. So then you restart the antagonist again after.
Yes, we restart the antagonist. We give 3 days of antagonist. We start our gonadotropins from the day 4. After the day we stop the antagonist, and then when we see the size of the follicle is 12 to 13 mm, we restart the antagonist.
Okay. Thank you, ma'am. Anybody else would like to ask any questions to madam?
At the outside, I just want to request each and everyone to support madam. And I am working with Basen madam. She's so meticulous in her work and taking everyone together. That is the best quality, ma'am. So I request everyone, madam is contesting next year for President Foxy. So I'm requesting everyone to support her.
Thank you, Brajbala, for your support and asking everyone to support. So I think everyone is now eager to listen to Kundan.
I think, may I request the chairpersons to introduce Dr. Kundan Ingle? And welcome, sir, we are eagerly looking forward to your talk.
Shall I or Dr. Rimi is there?
Yes, Dr. Brajbala, you can introduce.
Yeah. So, good evening, Dr. Kundan. It's privilege to introduce you, and you are a well-known figure in Foxy. Dr. Kundan Ingle doesn't need any introduction. He's having fellowship in endoscopy, director Nimriti Clinic, and sir was a chairperson AMOX Endocrinology Committee, chairperson Infertility Committee Foxy 2023, managing council member ISA 22-23, and Vice President POGS 23-24, and had been awarded many times. And we have listen his talk so many times. He is known speaker in Foxy, ISAR, IG. So we are eager to listen you, Dr. Kundan. Dash, it's yours now.
Good evening, everybody. Thank you very much, Chairperson, for those kind words of introduction. Today, it's a wonderful topic which has been given to me, and I'm very happy to prepare and give a talk on this because it's something new. As a clinician, I think we are always eager to listen to the newer protocols and updated newer information about ovarian stimulation as a clinician in ART, and I think it makes us more and more expert once we discuss all these things. So thank you very much, Isar. And just wanted to say at the beginning that if you always do what you always did, you will always get what you always got. So you can't just keep doing the same thing, because what you were getting before, you are going to receive the same thing. So unless and until we start thinking about newer protocols or newer things, we are not going to get extra. That is what is we are going to learn from this presentation. Every once in a while, a new technology and an old problem and a big idea is turning into an innovation. So this is what we need to understand, that new technology is our new protocol, and old problem is our getting a adequate number of oocytes, and third is a big idea. That big idea is something which we are going to learn today, that how we can individualize our ovarian stimulation protocol. Just let me put some charging point. Give me 1 minute. Yeah, thank you. So we are going to learn about the newer idea or a bigger idea where we target to achieve our main principles of ovarian stimulation, that is getting adequate numbers without having any negative impacts on the oocyte quality. So three principles of ovarian stimulation: one is to get adequate number of good oocyte quality, that is one; to prevent premature LS surge; and third is to prevent ovarian hyperstimulation syndrome. So these three principles, we always keep it in mind when we want to practice any protocol. Now, if you look at important steps, as I said, ovarian stimulation intention is to develop a more number of follicles at the same time. Second is to prevent LS surge, we want to do a down regulation. And a third is ovulation trigger for final maturation of oocytes. So these are the three important parts of the protocol. Now, just going to brush up some basic concept of ovarian stimulation in IVF. This is natural cycle. I think you can see my pointer. This is natural cycle where the FSH goes beyond this threshold, and once the FSH goes beyond this threshold, there is a recruitment of the follicles. Now here, this is spontaneous natural cycle. So FSH goes slightly higher, due to which there are two or three dominant, I mean, two or three follicles will get recruited. Once the follicle will start growing, they produce estrogen, and this estrogen reduces these FSH levels, and this FSH level goes below this threshold line, because of which two follicles will go into atresia, on only one dominant follicle will go into dominance. So this is our natural cycle. In IVF cycle, what we do, we start gonadotropins right from second day. So the FSH level, which is there between 5 to 7 MIU, it goes immediately very high, and the more high it will go, the more better oocyte recruitment will be there. So suppose we start with a 450 dose of HMG on the second day, then the gonadotropins levels are highest. Or even if you can start, as Dr. Archana Bas has said, recombinant FSH 300 IU maximum dose, the levels goes high, and there are not few follicles, but there are almost majority of the follicles will get recruited. Now here, though all these follicles are producing estrogen, we do not allow this FSH to fall down, because we continue the same dose. So steady dose or increasing dose, that is step-up protocol, is what is main crux of the ovarian stimulation in IVF. So we maintain those same FSH levels in the blood, because of which no follicle goes into atresia, and you may see a difference in the follicular size when they are growing, because of the individual FSH sensitivity of each follicle. Not every follicle is efficacy wise similarly FSH sensitive, means sensitive to the FSH hormone. So that's why we do see some kind of larger size cohort, then intermediate size, and then smaller cohort. So that's fine, but remember, maximum follicle will be recruited once you have a higher and higher blood levels. Keeping this principle in mind, let's understand two protocols which we most commonly use. One is a GnRH antagonist protocol, where we start gonadotropins right from second day. This is not a new protocol. This is what we are practicing today. We give for 4 days. Fifth day, we call the patient and we assess how many follicles are recruited and what size they have gone up to. Now, in fixed antagonist protocol, we add this Cetrorelix 0.25 microgram subcutaneously on this fifth day or maybe on sixth day. That is called fixed day protocol. So we start antagonist according to the day of the stimulation. That's called fixed antagonist protocol. There is another protocol where we wait till follicle goes 14 millimeters. Then we start antagonist, that is called flexible antagonist. So that somewhere comes on 7th or 8th day of the stimulation protocol. Now we do continue every scan, we assess the follicle size and we decide according to the follicle size, shall I continue the same dose or shall I discontinue, shall I increase the dose? Generally, by and large, we don't decrease the dose of gonadotropins in IVF specifically. So we continue the same dose and we continue the antagonist on the same day. And once the follicles are between 18 to 20 millimeter, the dominant ones, at least 4, 5, 6 follicles, and then that is the right day when we can give a trigger and then 35 hours. So this is one called GnRH antagonist protocol. Here the specific protocol varies because of the down regulation protocol type. Now, the second protocol by which we achieve a down regulation is a long agonist protocol. So here we give GnRH agonist as a 0.5 milligram per day right from 10 days prior to the expected menses. That is, if the cycle is 30 days, then 21st day we start. If the cycle is 28 day, then 18th day we start. So we ask the patient to take daily 0.5 milligram of agonist subcutaneously till she gets some menses. Once she gets some menses, on the second day, we start gonadotropins and also we continue same dose of GnRH agonist, that is 0.5 milligram. There was used to be an era where we used to reduce these dose to 0.25, but there is no need. We want to continue same down regulation effect till the trigger. So we do continue agonist till the day of trigger, and accordingly again 4 days gonadotropins, 5th day you assess, 7th day you assess, 9th day you assess. Once the follicles are ready, then you can give a trigger by SCG. But in this protocol, in this particular protocol, you cannot use GnRH agonist as a trigger because already agonist is occupying the receptors and the pituitary is empty. You have only option of using SCG. So with this background of normal protocols or usual protocols, let's understand what new protocols we have now in the literature, which is most commonly recently, like 2 years, we are discussing about random start ovarian stimulation, especially in women desiring elective cryopreservation of oocytes. So where do we do a elective cryopreservation of oocytes? Majority are the cancer patients because little they are in hurry to start their chemotherapy or radiotherapy, and that's why they come to you for quick cryopreservation of oocytes. And there we can't wait for day 2 of the menses or give them some kind of antioxidant. So you have a very limited time, maybe 2 weeks or 3 weeks, and then that time you need to get more and more oocytes. So this was the study in 2017 where 1302 women were recruited. Almost 66% underwent conventional protocol, and then 26% we started in early follicular protocol, 3.2% started late follicular protocol, and 4.5% started luteal ovarian stimulation protocol. So the duration of ovarian stimulation, that is random start, was around 11 days, and also total dose of gonadotropins administered were higher in the random start. So we need to understand that there are also pituitary hormones which reduce the growth of the follicles, like LH specifically. So majority time in random start protocols, you need little more gonadotropins and you need little more duration, like 11 days versus 9 days, especially in random start. But the number of total and M2 oocytes in the control and random starts groups were similar. So without compromising the number of oocytes, but with little disadvantage of having more gonadotropins, we will be able to achieve any time we can start this ovarian stimulation. So right, even we have almost so many ways. Like conventionally, we start on day 2. In early follicular, we start around day 12, day 13. The late follicular, early means even we can start at day 7, day 8. Late follicular is day 12, day 13, and even the luteal, where around day 17 or day 18 we can start. So let us understand, random start GnRH antagonist for emergency fertility potential. So this is a new protocol now. This was in 2015, where they said random start antagonist. So that is, we are trying to use, instead of agonists, we want to use antagonists to downregulate. So there are variety ways. Like for example, a patient come to you on 10th day, I means early follicular phase. So 9th or 10th day also you can initiate the GnRH antagonist. You have to give it till the estrogen level goes below 60. So once you give antagonist, you have to give it daily. So you can give day 10, 11, 12, 13, 14, start monitoring estrogen levels. Maybe 4 or 5 days or 6 maximum days, you will see that the estrogen level goes below 60 picogram. Now there you stop the GnRH antagonist, and that is the time you will initiate the supplementation of HMG or recombinant FSH. Again, the further protocol is very simple, like a fixed protocol. You give for 4 to 5 days gonadotropins, assess the response, and you add antagonist on day 5 or day 6 of stimulation, and you will continue the similar protocol ahead, like what we have understood in a standard GnRH antagonist protocol. So this is one protocol where we will do a kind of a little early follicular phase downregulation with antagonist, and once the downregulation is complete, then we can start. Now patient can come to you little mid cycle also. So again, similar concept you can use in a mid cycle or early luteal phase, where patient has come to you between maybe 14 days, 12, 14 days later or 15 days later. You can still give antagonist to this patient from day 20 of the cycle. Now you have to give again till the estrogen level goes below 60. Now remember, the antagonist is going to block FSH-LH, so there won't be any stimulation to the ovary. So estrogen level goes down, progesterone level goes down. So what happens is, once the estrogen is below 60 picogram, you can again stop antagonist, and next day you can start HMG or recombinant FSH, and the next protocol is again going to be simple. So what is random start is nothing but, you can any time of the cycle you can start antagonist, down regulate the patient with antagonist, and then you can start. See, again, I understand that antagonist incurs some kind of little more finances, because 5 to 6 days prior antagonist, then another 5 days after the day 5 stimulation. So 10 to 11 or 12 antagonist is going to involve little more cost. But remember, these patients who needs to go back to their chemotherapy, radiotherapy, they have a very short time. Majority times I have seen my practice, if you call them on day 2 for next cycle, they will never wait for that, because cancer is another fear, and there in front of life probably we don't think of fertility and give any importance to it. And that's what happens with this group of patients psychologically. And even if you insist on them or persistently counsel them, they go back to start that chemotherapy and radiotherapy earlier, rather than doing a fertility cryopreservation. So this is another, I mean, this is our control group, where the standard antagonist. So we have seen day 10 antagonist, we have seen day 20 antagonist, and this is a standard. So when they compared these three protocols in this 2015 study, again it's a self-controlled trial. So standard protocol, they got number of M2 sites around 14. When they started day 10 random GnRH antagonists, in that protocol they got 13 oocytes, and when they started GnRH antagonists randomly at day 20, they still got 13 oocytes. So frankly speaking, we are not losing on recruitment of any number of oocytes. So they are almost same, as well as they have documented that the ongoing pregnancy rates were also similar when protocol B, that is day 10 antagonist, and protocol C, that is day 20 antagonists, were compared with protocol A. So with that, we are not compromising our pregnancy rate also. The next protocol, which is, we can't say newer protocol, but it is a really recent protocol, like maybe 5 6 years, progesterone prime ovarian stimulation protocol. Again, all these protocols vary according to the agent we use for down regulation. So this GnRH, this progesterone prime ovarian stimulation protocol was compared with antagonist protocol in PCOS patient. This was a systematic review and meta-analysis in 2024. So total 8 papers were covered in this meta-analysis. 2,156 patients, women were enrolled. 1,085 patients underwent antagonist protocol and 1,071 patients undergone PPOS protocol. Now again, let's see the result that PPOS group was correlated with a lower risk of ovarian hyperstimulation syndrome and more gonadotropins dose compared with GnRH antagonist. So again, we have some slight of a little disadvantage of need of more gonadotropin doses, but the biggest advantage which we have understood the principles that lower risk of ovarian stimulation in comparison even with in comparison with GnRH antagonists. So no statistical difference were identified on the oocyte condition and pregnancy outcome. So without compromising our impact on outcomes or the egg quality, I think we are still good with PPS protocol. So in PPS protocol, just to understand, we start first injection on the second day of menses, that is HMG or recombinant FSH, and on the same day we ask a patient to take medroxyprogesterone acetate 10 milligram once a day, and we continue till the day of SCG along with gonadotropins. Your monitoring days don't change. You do a scan on first day of stimulation, fifth day of stimulation, seventh day of stimulation, ninth day of stimulation, and then followed by oocyte retrieval. So we still give in this protocol medroxyprogesterone dose on the day of trigger also, and even you have used progesterone, you can, if you feel that patient has a risk of ovarian hyperstimulation, you can use agonist as a trigger in this patient without compromising the oocyte quality. And but only thing is that we have to freeze all embryos because we have given progesterone, we have exposed endometrium to progesterone, there is advancement of endometrium, so implantation window will change or it will be advanced, so there will be lesser pregnancy rate if you do a fresh transfer. Now, next protocol is a dual stimulation protocol. Now, dual stimulation protocol is something we are trying to mix. Dual means there are two protocols which are combining together. Now, let us understand the standard dual stimulation protocol. The first part of the protocol, that is first stimulation protocol, is same like what you do conventionally. On the second day, you start gonadotropins, maybe fifth or sixth day, you start antagonist, you do give trigger as per the need, and you do a pickup. Now, once you have done the pickup, you have to wait for 3 to 4 days. And maybe after 3 days, that is fourth day from oocyte retrieval, that becomes a luteal phase. So luteal phase, you will start 3 days from the previous oocyte retrieval. Fourth day, you will start another stimulation with HMG. Here again, the protocol is same, that you will give 4 or 5 days of gonadotropins. Fifth day you give antagonist, and as per your need you will give agonist or SCG as a trigger. But here, because first day, first stimulation followed by second stimulation, we are not doing any fresh transfer, we are freezing the embryo. Again, the second stimulation in a luteal phase, so we cannot do a embryo transfer. So in both protocols, in fact, both stimulation followed by embryo vitrification. So you will have to prepare her for frozen embryo transfer in the next cycle. So here only variation is that instead of this having this, the BISTEAM study clearly showed that where 88 women with having poor ovarian reserve, they found that mean cumulative number of mature oocytes and total embryos obtained were not significantly different between the groups. Okay, so 44 were in a dual stimulation and 44 were in a conventional group. So if you do a dual stimulation, they did not find the difference in mature oocytes and total embryos. Another thing is that implantation rate was also similar between groups. The cumulative live birth rate was also not statistically different comparing controls versus dual stim. So really speaking, we did not find a much difference into dual stimulation against the conventional protocol. So probably it was not so popular for poor responder. But in fertility preservation for oncology patient, I think this is very good because you have again a small time, and if a patient can really give you one cycle, probably you can have in the if she is a normal responder or a hyper responder, you can safely have some 25-30 oocytes for her future fertility. Again, it's a wonderful protocol. to use it for fertility preservation for for these cancer patients. Now there is little slight modification which I will suggest, or rather our literature is suggesting, is how can we do a embryo transfer if it is, if at all we have to use it for the poor responders. Because in poor responders we are getting same number of oocytes, but we are putting a financial burden by preparing her in a different cycle for frozen embryo transfer. So what you can do is that you can call the patient in the first cycle directly on day 18 or 21 of menses. So that's a luteal phase. So what you are doing in dual stimulation, instead of follicular phase stimulation followed by luteal phase, what we should do ideally in poor responder, we do a luteal phase stimulation where we start gonadotropins, we add antagonists, we give agonists as a trigger, and we do a oocyte retrieval. Now after the oocyte retrieval, somewhere at that time she may have a withdrawal, uh, you know she may have a withdrawal menses as per her original dates. But suppose even if she doesn't get, 5 days later what you can do is that you can start a follicular phase stimulation. So probably you expect, because the estrogen levels falls and progesterone levels fall, she gets her menses. So around 4 or 5 days later she will get her menses, and second day of the menses or probably third day you can start the follicular stimulation. So what you do is the stimulation process is same. You start HMG, add antagonist. You can use agonist trigger if it is hyper responder, but in poor responder there is least chance. So you can give dual trigger here instead of only agonist. You use SCG as well as agonist and do a oocyte retrieval. But because you have used SCG, you can still plan for fresh embryo transfer in this patient. So you may have embryo ready in the first luteal stimulation, which you can thaw on the embryo transfer day. And also from second follicular phase, you will have some embryos where you can do a embryo transfer. So only advantage is we can do a fresh embryo transfer after second ovarian stimulation. So that is after second OVAR. So this is something, a kind of a modification in your dual stimulation protocol, which you can use it for your poor responders if at all you want to do for this kind of. Now this was compared with a single stimulation fresh embryo transfer protocol for the poor responder patient, that is young low prognosis patients, and they found that in duostim, that is luteal followed by follicular, first stimulation was initiated in luteal phase followed by second stimulation 5 days post first retrieval. So their outcome was significantly higher number of good quality blastocysts as compared to the single stimulation, which is a conventional stimulation. Even in secondary outcomes, which was ongoing pregnancy rate, they found slightly higher ongoing pregnancy rate. There's no difference in terms of statistical difference in terms of ovarian response, in terms of mean number of mature oocytes. So that was not much difference there, but they got a good blastocyst, they got a good ongoing pregnancy rate with this kind of thing and without compromising much of the time. Last about few points about newer protocols is estrogen pre-treatment before ovarian stimulation. I think that has become a norm now for all poor responder where we want to do a kind of a synchronous follicular growth in antagonist protocol. So what we do it here, that in previous treatment cycle we start estradiol 4 milligram per day from day 20 until next cycle day 1, means almost day 2. So day 1 patient takes estrogen and day 2 she stops and we start stimulation, and this was compared with the controls who did not receive pre-treatment and directly from second day they underwent a stimulation followed by antagonist administration. So they realized that in this patient group who had like a poor response but little non-coordinated response, so on day 8 follicles were smaller and their size discrepancy actually attenuated in the estrogen group compared to control group. And also they realized that giving estrogen group, they have more number of 16 or more than that size follicles, they gave more oocytes and more embryos. So luteal estrogen administration actually reduces the pace of growth, improves the size homogeneity of antral follicles on by the day 8 of recombinant FSH treatment, and increases the number of follicles reaching the maturation at once. So that asynchronous follicular growth is prevented in poor responder, which is we come across in almost 20-30% of poor responders. So we cannot identify majority times of these patients. So it is better to give estrogen to these patients, and then we can plan a oocyte retrieval. Now, it has been shown that there was a difference in serum estrogen levels between both groups. That was not statistically, difference if you look at the baseline or day 6 or day 8, but not on the day of SCG. Now, if you look at the luteal estrogen group, number of follicles which reached more than 16 millimeter on the day of SCG was 9.9 when you give estrogen, and when you don't give estrogen, and control group who just started conventional protocol, they gave 7.9, so significantly in favor of luteal. Even if you look at number of available embryos, they were significantly in favor of luteal estrogen group. So there are so many studies which has shown that the pregnancy rate is similar even if you give estrogen and even if you don't give. So probably with giving estrogen, you are able to achieve synchronous growth without compromising the pregnancy. Especially if you use it for poor responder, your cancellation rate in this group of patients in pre-treatment group will be much lower. In fact, you have a more better embryo, so you have a rate of frozen embryo increase by almost 5 times than you don't use estrogen pre-treatment. In normal responder, again, they found that the rate of frozen embryo percentage is 53 in pre-treatment group versus 41% in control group. So giving estrogen in normal responders and poor responders helps you achieve more and more embryo. Now, this is simple diagrammatic representation where on day 20, you started estrogen 4 milligram per day, continuously ask the patient to take it. Once she gets her menses, she still take it on first day, and tell her and counselor in prior that second day you will stop and revisit to the center where we will start a conventional protocol ahead. Now, last few points about one more is, though Dr. Archana Basir has given Goswami's study about adding letrozole in poor responders in, probably 2006 study. Again, there are recent trials which has come up after 2019, and they found that in poor responders where we are always struggle for number of oocytes. So this was 160 POR patients according to Bologna criteria, where they received along with gonadotropins 5 milligram letrozole first 5 days of stimulation in antagonist protocol, and second group did not receive letrozole, and they found that we got higher number of oocytes, higher number of mature oocytes, lower doses of FSH, lower duration of stimulation, and improved clinical pregnancy rate, which was not significant, but we got better number of oocytes and M2 oocytes and embryos also. So letrozole has an advantage in poor responders, especially in poor responders. The live birth rate significantly increased by 7% with letrozole co-treatment. Even in normal responders, the number of oocytes retrieved, they were increased with 1.8 oocytes more with letrozole co-treatment, but letrozole has got no role in hyper responders because there is no effect on live birth rate and clinical pregnancy rate. Coming to last point of the protocol, and that's the ovulation trigger. I think we have understood the downregulation in your protocols. We have understood the different adjuvants which we can use it to have a more better number of oocytes. Let's understand the final step of ovarian stimulation, and that is ovarian trigger. So remember, if you use agonist as a trigger into your protocol, you need to have an adequate LH surge. And this is what has been studied in this study of 2012, where 12 hours later, when LH was assessed after your agonist trigger, patients were divided into different groups according to their LH level. So LH below 15, 15 to 30, 30 to 45, 45 to 60, 60 to 75, more than 75. And they found that whenever the LH levels were below 15 after the agonist trigger, there was statistically significant reduction in the oocyte yield. So what we need is anything above 15 will give us a better oocyte numbers. So please keep checking the LH levels every after your agonist only trigger. And the quality wise, if you look at SCG versus dual trigger, which is another norm now in poor responders, we found that number of oocytes retrieved are significantly in favor of dual trigger. Even M2 oocytes were significantly better. Total number of blastocysts were better. Top quality blastocysts was significantly higher. The pregnancy rate, the live birth rate, all were in favor of dual trigger. So now dual trigger is something which we will follow it almost normal responders or poor responders. but you will avoid it into hyper responders. Now, this was a comparative study between single versus dual trigger for poor responders, and this was randomized control trial. Clearly, they said that dual trigger is associated with a better IVF outcome in poor responder compared to a single. Now, this dual trigger is also studied in intrauterine insemination, though it's not a topic of my, but I wanted to cover up and give a message to the all my friends and delegates that start using dual trigger in IUI. It gives you fantastic results. So, like in this study, they have clearly shown that when you give only SCG in a IUI treatment, you can achieve 12% clinical pregnancy rate. But if you use dual trigger, your clinical pregnancy rate is almost double of 28%. Okay, so this was a good study which has given us a clear idea. Even the OHSS rate was not significantly different. It was 2.6 versus 2.7 because the ovarian stimulation is mild in IUI. So we are not worried about OHSS. In case accidentally if you get OHSS in IUI, probably you don't need to give dual trigger. But for standard 2 or 3 or 4 dominant follicles, probably start using dual trigger. You will understand that now, where we used to always say that we cannot achieve any pregnancy beyond 17%, now we can go to 28% with the dual trigger in IUI. So friends, successful people are not gifted. They just work hard, then they succeed on their purpose. And our greatest weakness lies in giving up. So don't give up. We want to achieve more and more success rate in IVF. The most certain way to success is always to try just one more time. So I hope that I could contribute some kind of a new addition to your knowledge of ovarian stimulation, which you have to try. Unless and until you try, you may not be able to understand the importance or benefit of that particular. So perfection is not attainable, but we chase perfection. We can catch our excellence, and that is what is my message to all of you. So thank you very much for the patient hearing, and I'm very happy to give this lecture during this MP chapter webinar of ESAR. And thank you very much to MP team, MP ESAR team to give me this chance, and to also Dr. Amit Patki, ESAR president, for inviting me to this talk. I am happy to take any questions if at all they are there.
Nice lecture, Kundan. Really enjoyed.
Thank you. Thank you very much.
Thank you, Dr. Kundan. It was excellent talk, and you covered trigger also. That was dil mange more wali baat ho gayi.
Thank you very much.
Thank you so much.
I wanted to let the participants know that they can, post their questions in the comment box in case, and then our experts will answer them.
Yeah, sure.
Thank you, Dr. Kundan Ingle. That was an absolutely excellent presentation and very, very fantastic take-home points. I think all of
Thank
us
you.
have a lot to learn from that.
Can I ask one question with Dr. Kundan? Is Dr. Kundan here?
Yes. Yeah.
Dr. Kundan, you were saying for long protocol, like I'm old school thought person, so I used to reduce the lupride dose once we start stimulation from 0.5 to 0.3. But as you were saying, need not to reduce the dose from day 2 when we are starting with stimulation. So what is the significance of this?
Yes, actually, when this was a practice even a decade ago, wherever we used to use, we used to give 0.5 and then we used to reduce 0.25. But then we realized in few percentage of cases that when we reduce to 0.25, at the end of stimulation, there is a little higher LH and there is a little higher progesterone. So we are losing somewhere in certain cases that down regulation effect of GnRH agonist. And then when we started doing the continue the same dose, we did not find these kind of results. So even the literature has compared these two, and they said that probably you don't need to reduce the dose. What is important is that we need to have a continuous pituitary suppression, so that we just don't want LH and advancement of endometrium due to little early rise of progesterone by the day of SCG. So probably that's why my intention was that we have stopped doing it in almost a decade now. Wherever we used long agonist protocol, especially in poor responders who have a asynchronous follicular growth on antagonist, we generally go for agonist protocol in this group of patients. Otherwise, majority other patients are undergoing ovarian stimulation with antagonist only. only in this selected patient. So 20 units will give you a security. It will not allow any premature LS surge to happen in your majority of the cases. So you will not get a patient who's got a high progesterone on the day of trigger. So that's why it is.
Thank you so much.
Dr. Kundan, I have a question. Am I permitted?
Oh, please.
Yes,
Achha, so, you finally told about the trigger. So you mentioned about the LH levels less than 15 and the poor oocyte yield after that. So you mentioned about the dual trigger. So are there any studies wherein how they measure the LH level post recombinant HCG versus LH levels after the HCG plus 1 milligram leuprolide?
Okay. Now, first of all, when you are using SCG as a trigger, probably you don't need to worry because you don't, it will not reflect into your serum LH level. The SCG is going to act on the ovary directly, number one. But if you are asking me about dual trigger, where you are giving SCG and you are giving LH, probably even there you don't need to do any LS levels because already even if there is no LS surge by any chance or inadequate LS surge, the SCG part is already there. So probably I won't say that it is mandatory to do LH, but what happens in only GnRH agonist trigger because there is nothing else. If you don't get an adequate LS surge, we are going to majority times land up in a poor oocyte maturation, and also there is a high possibility of empty follicle where probably because of inadequate very low LH, the oocyte cumulus complex is not getting separated from the follicular wall, and with your 90-100 millimeter of mercury you won't be able to aspirate that complex. So what we see is empty follicle on outside picture. So that's why it is important that 12, it's not 12 but it is minimum 8 hours, you have to give 8 hours. So you can do even at 8 hours, and 8 to 12 hours if you check the blood levels, the LH levels once they are more than 15, I can tell you this is my practice since 1 year. We have been kind of could diagnose one or two patients who actually did not have LS surge. So we could save that empty follicle. We did not plan that as per our original plan. We gave a second trigger and then we gave. So sometimes we give agonist as a only trigger in hyper responders. But if we have given agonist and patient has not had any LS surge, there is no choice than giving a SCG. Okay, that low dose SCG might be helping, and then you have to apply for prevention of OHSS strategies or therapeutic strategies to manage that OHSS. But of course, one of the case what we did is that LH was absolutely below 2 and there was no LH surge, and the response was so exorbitant that we finally thought of that let's not give anything, let's not give SCG also, because if I would have given even 5,000 or 3,500 SCG to this patient, my patient would have given me 40, but the problem she would have faced severe OHSS in next week. Probably I cannot manage that so easily. She would have had a lot of morbidity. So we boldly counseled patient and we said, no, we are not giving any other trigger to you and we are abandoning this case, and we are just going to give you some antagonist for some time just to suppress ovary and abstinence. So sometimes you have to take such harsh decisions, but you try to save any single case of severe OHSS where she will land up into hospitalization and lot of monitoring. So LH is something which I will recommend because even slightest one or two cases of empty follicle, probably which is easily preventable, you can diagnose this in time. So all single agonist trigger start monitoring with LH, and you will be able to be saved from empty follicular. That's really really rescue situation for us. Sometimes if you have very low levels of LH, so at least you can tell the patients that this is the issue right now. You cannot, so suppose LH levels are only 15 or 16 or 17 or even 12, so you can at least counsel patients that probably the picture which we have got it, that less M2 sites is a result of that. So there is some kind of explanation that instead of having good ovarian response, still we got a less number of M2 sites. So I think it's a logically good decision to monitor LH level after your agonist trigger.
Sir, I have one question. Can I ask,
Yes,
Amrita?
please,
Is that
Anand.
okay?
Yes,
So
Anand.
thank you so much for this lovely talk,
Thank
both Dr. Basair and you. So with regards to LH levels, 12 hours after a trigger, LH has a quite a short peak. So should we be even monitoring serum progesterone to be on the safer side pre-trigger and post-trigger 12 hours? Is there
Right.
any cutoff for serum progesterone?
To be honest, checking progesterone level, because even the LH in agonist trigger goes to peak at 12 hours and it really falls back to almost less than 5 by 20 hours. So even if after that peak, you need at least 12 to 16 hours more for progesterone production. So suppose you have given a trigger at 0 hours, 12 hours the LH peak is there. So your progesterone levels will come into circulation somewhere around 26, 24 to 26 hours. So that 12 hours progesterone may not help you because it will be still low. So
Okay.
probably with those low progesterone levels, you will get more confused. So I won't recommend that. So yes, you can do 26 hours, but probably it may not help us because
Yeah.
by that time your LH level has given you security. So that's
Okay.
why progesterone levels may not help by 12 hours.
Okay. Thank you, sir.
Sir, I have a question. Kundan sir.
Yeah,
Yeah, may I?
yeah,
I wanted to ask regarding adjuvant in poor responder, though your talk was on stimulation protocols.
yeah.
I mean, DHEA plus CoQ combination, recently they have discontinued 75 milligram DHEA with coenzyme Q10. But clinically, practically, we have seen very good results all these
Yeah.
years, and suddenly
We-
they have banned and discontinued this combination. So, what is your take on it, and what is your experience on using these adjuvant pre-treatment
Yes.
and during stimulation in poor responders?
Yes, that's a good question, but we need to understand DCGI has disapproved the combination. That doesn't mean that DCGI says that don't use it for the poor
Mhm.
responders. So what
Correct.
simple take-home message is that you have to use DHEA, you have to give CoQ 300, give it separately. Okay, the
Okay.
combination they have banned it for whatever reasons. We don't
What
want
is,
to go into
yeah,
detail, but
what
that
is
is
the
not.
reason
Yeah.
of-
So you can
Okay.
still use the same molecules. Only thing is that the formulations are going to be different and individualized. I mean, not individualized, separate medicines. The combination, they are not allowed it. That's all.
Okay. So, just asking, what is the reason of discontinuing or putting a ban on the combination?
Okay.
What was the issue? If
I really don't know, to be
if
honest,
you can
but
throw a light.
because there are a lot of politics behind it. There are a lot of politics even from the bigger pharma to the smaller pharma. I think we need to
Okay.
understand that. Otherwise, there is not a bigger rationale. I mean,
Okay.
there is
Okay.
no drug
Exactly.
interaction. To be honest with you, there is no
Exactly.
drug interaction. Okay,
Okay. Okay.
pharmacokinetically, probably they do say that if you combine androgens with coenzyme Q, the coenzyme Q efficiency goes down. I really don't know. I'm sorry, really don't know.
Yeah.
But we cannot go and ask DCGI that why did you have? So we don't get any explanation. But I think let's follow
Understood.
the message by DCGI. We don't want to use it. Fine. Well, we can. We have a
Use it
evidence that DHA is
individually.
required. We have a evidence that CoQ is required in 300 doses. So we must use it the same adjuvants for all poor responders,
Okay. Thank you.
expected poor responders. Yeah.
Let's move
So,
on to the panel. Panel, yeah. So Amrita, let's move on to the panel.
yeah.
All panelists and our moderators are.
Yes, I would like to invite Dr. Ditya to now introduce the moderators and our panelists after that very
Yes,
amazing
ma'am.
brainstorming session.
Yes, ma'am. Yes, ma'am. I would really want to thank Dr. Kundan sir and Archana Masih ma'am so informative lectures for our youngsters. Now I'll start our panel discussion on topic pregnancy outcome and poor responder. I would like to welcome Dr. Rajkumar sir and Dr. Tejas Gundewar sir. Please display the CV. Dr. Rajkumar sir, he is senior consultant gynecologist and Nanavati Max Super Speciality Hospital, Mumbai, and medical director and Eva Medicare, Mumbai, Thane, and examiner ICOG and RM course, immediate past president and associated fellow gynecologist, vice president in SOVSI, and visiting fellow in gynecologist endoscopy, reproductive endocrinology, and infertility. And he has a special interest in gynecological endoscopy, infertility, and recurrent pregnancy loss and emergency obstetrics. Now, I would like to welcome Dr. Tejas Kundewar, sir. He's a fertility consultant and andrologist in Jeevanam and Ruby Hall Clinic, Pune. He has got many achievements in the endocrinist training, and first MCH in reproductive medicine and surgery from Maharashtra, and gold medalist. Recipient of MRCOG London, and done many publication and got the credit in Haryana Open and Andrology and IGGO. Had a field of interest in natural conception for infertility couples and male subfertility and recurrent pregnancy loss and recurrent IVF failure and diminished ovarian reserve and oncofertility. Now I would like to invite our panelist, Dr. Mahesh Koregal sir. He is exclusive in fertility and IVF practice for more than 17 years across India and Africa. And he is senior in fertility and IVF specialist consultant in Bangalore, National Strategy Director, Nova IVF Fertility. Got many achievements and achievements in many ICOG centers and chairperson in KSOGA 2021 to 2022, member of Foxy Endoscopic Committee, and member of Foxy ISAR and KISAR, IFS, ICOG, IAG, and ACE. Had many teaching positions in many centers and many hospitals, academic excellence and reviewer of General and International Journal of Infertility and Fetal Medicine. Published 5 research papers at International Scientific Journal at first author and co-authored several textbooks of infertility. Dr. Pinky Shah, DGO, DNB, FNB, Fellowship in Reproductive Medicine. She is Medical Director in Dheeraj Vanesh Fertility Center, Dhule, and Fertility Expert, Seva Super Specialty Hospital and Critical Care Center, Dhule. Now I will invite the next panelist, Dr. Sachin Dalal, obstetrician, gynecologist, lab surgeon, and IVF specialist, and many affiliation in Madhu Hospital, Bhandup, Embryon IVF Vikhroli, Fortis Hospital Mulund, Jupiter Hospital Thane, and Surya Hospital Chembur. Please just play the next panelist. Please just play the next. Dr. Kanchan Morarke. She is a senior gynecologist and IVF specialist and attached to Institute of Human Reproduction, General Secretary of NESR Society, and Assistant General Secretary of GOGS and past Treasurer of NESR Society, and have many experience for 20 years in the field of infertility. Dr. Tejal Podar, she is consultant obstetric gynecologist and fertility specialist, director of Little Miracle Fertility Clinic, Opera House, Mumbai, and she has special interest in fertility and high-risk obstetrics. Dr. Sridevi Tangsale, she is consultant obstetric gynecology fertility specialist in Little Miracle Fertility Clinic, and done DNB and OBS-GYN, DGF, FRM, FMAS, and consultant in OBS-GYN at Surya Hospital, Criticare Hospital, KLS Memorial Hospital, Apollo, Spectra, Cardio, and Baba Saheb Gawai Hospital, SRCS Hospital. Dr. Jasneet Kaur, she is clinical director and consultant at Milnan Fertility Center, Chandigarh, and co-convener in IFMS Fertility Preservation, SIGS. And next, please. Dr. Nupur Chathasya ma'am, Spring Fertility and Women Clinic, Surat. She has done MD in OBS-GYN, DNB, FSUH, Fellowship in Obstetric Ultrasound and Mediscan, Chennai, IVF and ERT training, Cleveland Clinic, USA, ICOG Reproductive Medicine Fellowship in Pune. Dr. Anand Nanavati sir, DNB MRCOG, director at Create IVF and Fertility Center at Mumbai, and visiting consultant at Nova IVF, Surya IVF and Hospital, managing committee member for IFS Mumbai chapter. Dr. Jasmeen Kaur Dhaya ma'am, she has done IVF high-risk pregnancy and reproductive endoscopy, vice president in Punjab Medical Council, and ex-chairman, chairperson SR Punjab, Chapter Punjab, vice president of Foxy Jalandhar, and WDV chairperson IMA Punjab. And she has been awarded in many IMAs and first woman to be elected at PMC. Thank you so much, ma'am. Now I would like to share my screen to the moderator to start the panel discussion of today's CME.
We welcome all the moderators and all the panelists from MP.
Thank you, madam.
Thank you.
Thank you,
Thank
ma'am.
you.
Thank you. Thank you. Thank you.
Ma'am, can I start sharing the screen?
Yes, please, let's start.
Okay, just shall I do it?
Sir,
Yes, sir.
there are
Yes, sir. You
changes
can
in
start.
that, no?
Yeah, because I just done it. Fine, 2 minutes. Just yeah.
I will share, sir. Because
I may record. Then we'll record just because we didn't have any coordination. I think okay, no problem. Go ahead.
so it's the same thing, sir, but
No, I have changed it.
we've
Yeah.
added. So you can start.
Yeah, so I think let's go on to the next slide. I think will you be able to change from your side?
Yeah, absolutely.
Let's go to the next ones.
So
yeah, go ahead, Tejas.
So, sir, you're taking it?
No, I think you go ahead. I will interject whenever it's possible.
Sounds good. So, good evening, everyone. I am Dr. Tejas Gundewar and Rajkumar sir. Both of us would be.
The problem here, Tejas, and all the organizers, is we have 10 panelists available, and it's going to be difficult to ask each and every panelist as to how things are going to happen. So there has to be some way of, responding. So probably we'll be just asking questions and maybe raising hands or, some way that somebody would contribute. Otherwise, one point will be discussed by 10 people. So it's going to be a little difficult. Just put up with us. Let's see how things go. Yeah, go ahead.
So, myself and sir would be moderating this panel on optimizing ART outcome in poor responders. I welcome all the panelists for this panel discussion. So, what we're going to do is we brush through a few basic definitions of different categories, and then we take a couple of real case scenarios where we discuss practical tips and points of how do we go ahead. And then I think anybody can take the questions. Whoever is ready to pitch in, they can give their opinions. So before we go to the real case scenarios, I think let's get from all of you that how do you categorize ovarian response after a conventional ovarian stimulation? Anybody can take it.
Yeah, so can I take this?
Anand,
yes. Yes, absolutely. Anybody can take it.
Earlier on, there was a Bologna criteria that we had, which just included, the patient's age, the AMH, and the antral follicular count. But currently, we have categorized this in terms of Poseidon, which is more, gives us more information. There are 4 groups that we have: Poseidon 1, 2, 3, and 4. Basically, these are groups of poor responders mainly. If you go on a broader term, we start with, you have a normal responder where we get about 10 to 20 oocytes. More than 20 oocytes, that is obviously hyper responder, and a normal poor responder is less than 10 oocytes. So hypo response, as you mentioned, is less than 10 oocytes, and in that we categorize, amongst Poseidon groups, which is 1, 2, 3, and 4.
So basically, a part of it is correct. So basically, these are objectively the number of oocytes that you get. You categorize your ovarian response after conventional stimulation. So a poor response is considered where your number of oocytes that you get is less than 4. A suboptimal response, which is 4 to 9. A normal response is considered as 10 to 15, and hyper response is considered as more than 15. So anybody would be able to tell me that what is the concept of an hypo response? So all these things we have discussed regarding exact number of oocytes and response. Anybody can throw some light on what is hypo response? So based on follicle oocyte index. So if all of us are aware of this new concept where a follicle oocyte index is considered, and what is follicle oocyte index? Where you are taking into account the number of oocytes that are retrieved divided by antral follicle count into 100.
Yeah,
So,
this is different from FORT,
correct.
follicular
This is
output ratio,
different
where
from
we look at
follicle output rate.
yeah, pre-ovulatory follicles, the follicles that are present on the day of HCG, divided by the AFC is the FORT. And for this thing, follicular to site oocyte index is basically number of oocytes that you've retrieved divided by the number of AFC multiplied by 10. Yes, go ahead, Teja.
So basically, let's take this example where what do you say as a normal follicle oocyte index? Say, for example, at the start of the stimulation, you have 10 antral follicles and you end up with 8 oocytes, which means your follicle oocyte index is more than 50. Out of 10, you've got 8. So where your follicle oocyte index is more than 50, which means you have ended up doing a decent stimulation, which we can say that it's not a hypo response. You have tried to optimize the ovarian capacity of this female. And similarly, if the same patient where your number of antral follicles was 10 and you ended up with, say, for example, 4 oocytes. So in 4 oocytes, this will be considered as a low follicle oocyte index, or which will be considered as a hypo response. So this is a new concept where we talk about follicle to oocyte index instead of ovarian sensitivity index, or Rajkumar sir said about FORT, follicular output rate. So follicle oocyte index is the one that defines what is a hypo response and what is a normal response. And Dr. Anand told us about the number of oocytes that are retrieved. And that is, depending on that, we divide it into a poor response, normal response, suboptimal response, and a hyper response. So my question to all the panelists is, why do we want to actually optimize the number of oocytes that we want that are obtained? Why do you want, or why are oocyte numbers important?
Can I take
Can I
that?
answer this?
Yeah, please.
Sure,
Yeah,
go
yeah, yeah.
ahead.
So we want to optimize the number of oocytes because we want top quality embryos. So depending on the amount of number of oocytes we get, we'll know how many top quality embryos we get. So even if we get around 15, which is a normal oocyte rate, correct. So the number of euploid blasts that we get if you see in this paper, the euploid blast you're getting it as 1 euploid compared to 5 M2 oocytes. So as many number of oocytes we get, we are hoping to get a better yield and a better euploid blast that we are trying to achieve.
Absolutely correct. So basically, we want to we want to have an optimum number of oocyte because that defines what number of euploid blastocysts that you get, eventually defining the pregnancy
And
rate or
one
life
point
rate.
I'd like to say that age is a very important factor in this entire chart if you see. So as the age increases, the number of oocytes required to get 1 euploid blast is increasing. So age factor is something that we need to keep in mind, most importantly when we are stimulating a poor ovarian response.
Correct. Absolutely. So this was an excellent paper by Polizos where they showed that what number of oocytes, the categories that we spoke about, poor response, a suboptimal response, a normal response, and a hyper response. So you can see in this paper that the cumulative live birth rates when less than 3 oocytes, 3 or less than 3 oocytes were obtained was 21.7%. 4 to 9 oocytes were there. It risen to almost double that, which is almost 40%. With 10 to 15 oocytes, 50%, and more than 15 oocytes, 60% plus. So, as Dr. Tejal already said, that more the number of oocytes, better is the cumulative live birth rate, and that's why you would like to optimize the number of oocytes that you have obtained.
And this is why we are looking at newer protocols and most importantly dual stim, because we are hoping to get more oocytes in dual stim so we can get more blasts.
In a short time.
Yes, in a short period. Exactly. That is the advantage.
Okay, Tejas, if you can just stop sharing, I'll start sharing my screen.
Okay. You can share, sir.
You'll have to stop sharing.
And I'll stop. Now you can share.
So can you see my screen?
Yes.
Yes. Okay. So this is the first case that we are going to discuss. Okay, so this is a patient that we are dealing with. Is a 29-year-old Mrs. X married to Mr. 33-year-old Mr. Y since last 4 years. And the problem is that they are unable to conceive for the last 3 years. Cycles, her menstrual cycles, history cycles were regular with a moderate flow for 20 to 30 days cycle duration. There was no significant surgical and medical history. And the prior treatment history was that there were 2 failed IUI cycles, followed by 1 failed IVF cycle, which was last year with the antagonist protocol. During that time, there were 3 oocytes that were retrieved. Only one was fertilized with ICSI, of course. After 3 were fertilized, only 1 grew up to the 6 to 8 cell stage, and which was vitrified. And then transfer was done in the HRT cycle, no conception. The main issue there was endometrial thickness was much lower. About the male partner, besides oligoastenospermia from the previous semen cycle, semen analysis, there has been no other positive history that we could get. On physical examination, almost everything was normal, but was point of note was the antral follicle count on the right side was 5 to 6, on the left side was 6, and the day to LH was 2.9 million national units. In the male examination, there was nothing significant that we found. These are the workup of the hormonal profile, of which her AMH was 1.54, which was, to be considered when we are discussing. So it's not that bad an AMH and would not fall into the poor prognosis kind of group. So maybe she's in either 1 or 2. All other parameters were within normal limits. The semen analysis showed that the count was 4 million per ml, and other things were okay. Sperm DNA fragmentation was done in the previous, when the failed IUIs were there, that was 26%. So what we did was something on pre-treatment in the second cycle. She was given this transdermal testosterone gel, 12.5 milligrams on a local application from day 1 of the cycle. Letrozole 2.5 milligrams daily was added for 28 days. CoQ10, Kundan just mentioned about it, but CoQ10 we were using 400 milligrams daily. Injection HCG was given 5,000 units once a week. The cycle control was performed with administration of estradiol valerate 8 milligrams daily from day 3 to day 14 and 4 milligrams daily from day 15 to day 24. Added to that was micronized vaginal progesterone 400 milligrams daily from day 15 to day 24. Human growth hormone 0.5 units was started from day 21 onwards till the day of trigger. And during this time, she went through an operative hysteroscopy, which was done premenstrually. PRP injection was done at 5 sites subendometrially to facilitate endometrial thickness and receptivity issues. Now, this is her stimulation chart. What is important to note is the antral follicular count here and the steady increase in estradiol levels all throughout the cycle. We were using a combination of recombinant FSH and LH percovirase, and added to that was gonal F in a dose of 150 to 150. And this is the stimulation that she went through. The estradiol levels were perfectly fine. The follicular growth was fairly good. A trigger was given on the 10th day, and rather the 11th day, after the follicle size were good. And the post trigger, the LH levels were 24.8. We were just discussing about, this was a dual trigger that was given. And we were just discussing about, Kundan was discussing about the LH levels. The LH levels, 12 hours post trigger was 24.8. The progesterone level, which is done because she was given HCG also, so which was 5 point something. And Anand asked a question about progesterone. So here, anything more than 3 nanograms would be good enough as such. So there we are sure that probably we will not be dealing with an empty follicle syndrome. Subsequently, the oocyte pickup was done, there were 3 oocytes which were retrieved. All three were M2 oocytes. They were fertilized by ICSI, and we on the day 3 we had 2 embryos, one grade C and one one 8 cell and one 8 cell grade A embryos, which were done. Fresh transfer was done that particular cycle, and we could get a pregnancy there. Now here the oocyte retrieval was done with one single lumen needle, and all follicles were aspirated. Patient was put on micronized vaginal progesterone 800 milligrams per day per vaginally. Embryo transfer was done on day 3, as I mentioned, and dihydrogesterone was added. Post 80, the beta HCG was 100. So we could achieve a pregnancy here after having failed 2 IUIs and 1 failed cycle of stimulation of this IVF. I think we'll just go on to the next part. Can you see my screen now?
Yes, sir.
Okay.
No, we can see you. We cannot see the screen.
Can't see the screen.
Can't see the screen.
You can't see the screen?
No. Sir, I have one question in this
Yes.
andro IVF stimulation that you did in the previous cycle. So why did you reduce the estrogen? I mean, the 8 milligram you give till day 15, and then from day 15 it is reduced to 4 milligram.
Yes.
So,
that is
so why do? So, but in physiologically we increase the estrogen, no, sir?
No, usually the 4 milligrams is the dose, as Kundan mentioned specifically about day 22, till the time that period comes, it is 4 milligrams. So that's how it is.
And, so along with progesterone, you are giving the estrogen too for the cohort.
Yes. Okay. I'll just stop sharing here. I don't know how things are not working.
You want to stop screen sharing?
Yeah.
So there's this red button. You're at the top, you will see stop screen share. It will be there.
Yeah. Is that okay? Yeah, I'm just sharing the next screen.
Yeah.
You start seeing it?
No.
Just half a minute. Yeah. Okay. Yeah, fine. Yeah, okay.
Yes, we can see.
Yes, we can see.
Yeah. So as we were discussing, one of the most difficult problems in current practice is how to best counsel such patients and treat patients with a poor ovarian response. 2 reasons why a low number of oocytes may be collected is first, patient's individual capacity, that is diminished ovarian reserve. And the second is hypo-response, which Teja has mentioned very clearly. Capacity is higher, but stimulation is not optimized, and that is why we call it a poor ovarian reserve. So there are different problems in the management of decreased ovarian reserve, and we are going to discuss them one after the other in the case presentation. So do you believe in pre-treatment medications, manipulations that augment the response? Or does pre-treatment increase the potential number of recruitments or optimize the response of available follicles or oocytes? Can anybody tell me this?
Yes, sir. Yes, sir. I think pre-treatment is definitely a boon because these are the patients where we are really desperate with, and we do not have a lot of things to offer to them other than our conventional protocols. Of course, we have the newer one like the novel IVF, the andro IVF protocol. But yes, for such desperate situations wherein we need additional good estrogen priming is what I feel gives a good synchronous cohort. So these are all these supplementary things which help us to optimize the response, and like you rightly mentioned before, also get a good FOI, so that whatever follicles she has, we utilize them with a good amount of gonadotropin dose, so that we get more number of oocytes, better quality oocytes, which in turn transforms into a good quality embryo. And that's all what we need, a good top quality or euploid blasto to achieve a good clinical pregnancy and a live birth rate. So when you are asking me, the estrogen priming is what something I think gives a good synchronous cohort, and that should be used as a pre-treatment. Typically 7 to 8 days of 2 milligram BD dose would be fine. And other adjuvants that I would also like, of course, the CoQ and DHA are two things which help in improving the response to gonadotropin. So those two are also an additional adjuvants which we should add to the previous cycles for few weeks.
Yeah, Sachin is a fond person who likes to use DHA. So Sachin, can you just talk about this? Sachin Dalal?
I don't think so, he's there.
He was there earlier, no?
Maybe he's
fine.
not.
Okay, fine. So what has been seen is with the use of DHA, and this has to be at least 3 to 4 months before the ovulation starts, because this DHA is going to act on those follicles which are going to come up after 4 months. This is as per the originator, Norbert Gleicher's hypothesis, that you require to give this at least for 4 months. In fact, in his experiment, what he had shown was that, not experiment, his experience, that there were a lawyer patient in whom he was using this. She was having DHA as an over-the-counter medicine. Her follicular output started improving after the 6th cycle. So this is how it has come into existence, and people have gone back and checked how things are. So how does DHA improve? It improves primordial follicle recruitment as per Gleicher, number of pre-enteral follicles and oocyte yield, and improves oocyte and embryo quality and meiotic maturation with a consequent reduction in aneuploidy and miscarriage rates. This is the originator, and an originator will always have a good success rate. There's no question about it. Nobody can match that success rate. But what has been seen is that several groups reported DHA supplementation increases the number of oocytes and embryos, leading to improved IVF ICSI outcomes in patients with POI. An IVF worldwide survey showed that 26% of IVF clinicians use DHA as an adjuvant to poor responders. But what is more important is DHA treatment in patients with lower DHS levels less than 180 micrograms per deciliter had a more pronounced effect, providing greater possibility of attaining more than 3 oocytes. So this is important to understand, that you have to do a DHS level to find out whether this patient is going to optimally respond or going to be suboptimally respond. It is necessary to differ definite conclusions, because it requires a well-designed RCT and standardizes treatment and categorizes specific pure population that might benefit from DHA treatment. So everybody feels that it works well. Whether it does or not, we'll come to know with the different RCTs that have been shown. And what is Cochrane data saying about this? Pre-treatment with testosterone likely improves, and DHA response has no difference in live birth and clinical pregnancy rates in IVF for poor responders. DHA and testosterone probably do not decrease miscarriage rates, and effect on pregnancy rates are uncertain. So one thing is certain, that testosterone and DHA to some extent may help as such, but there is no difference in live birth and clinical pregnancy rates in IVF poor responders. Yes, Tejas, anything else would like to discuss, or do we go on to the
I think one point Dr. Sridevi was making, that we should means giving coenzyme Q10 and something else. What did you say, Dr. Sridevi? Coenzyme Q10, and you were saying something, right?
DHA, I think. DHA.
DHA. Okay, so I think estrogen you spoke about. So estrogen, I think
And testosterone gel also is a
pre-cycle programming with estrogen and antagonist. Maybe we can improve the synchronized follicle recruited at the time of the cycle.
We are talking about two different issues. One is synchronization of the follicle.
Correct.
So for which we have different options that are available. So either you use an estrogen to synchronize, or you go for an ergonist protocol, or you go for a GnRH antagonist in the luteal phase. In whichever way, the idea is to get a synchronized cohort of follicle. And then you have coenzyme Q10, DHEA, all these things. Whenever we are planning to give these things only in the preceding cycle, I think the aim is to improve the egg quality, oocyte quality is improving. The aim is to improve the oocyte quality. And as sir is saying, Rajkumar sir is saying that whenever you want to actually increase the oocyte numbers,
Yield.
You need to give it for a prolonged period of time. You need to start it 3 months prior, and then you can expect that probably you will have a better number of oocytes. In my experience, I think giving DHEA has not made a difference in the number of oocytes obtained. I think everybody can have their own opinions, but according to me, it does not significantly increase the number of oocytes that you get, even if you give it for 3 months.
Anybody has experience
Can I
on
just
testosterone
add
gel?
some? Sorry.
Yeah.
Yes, sir, I have
Testosterone gel. So can I
I have used
talk about
Yeah.
testosterone gel?
Yeah.
Testosterone gel, I have seen it works quite well in an older age group. So your Poseidon 2 and 4, and especially 4. And in that you have to start 1 cycle prior. Use take 1 actuation per day for about 28 days, and then you stop. Now testosterone gel also, in terms of as Dr. Tejas said, in terms of egg quality and embryo quality, not much difference, but it does increase your response to the gonadotropins. It increases the number of days of gonadotropins that you need, because what it does is it in these patients you need the androgen levels to be there in your follicular fluid, so that the granulosa cells are more receptive to FSH. So it increases your receptivity to FSH more than anything. So it does not translate into
in elderly patients, I have also used testosterone gel, and I find that there is in the patient who had previously poor response, when I'm giving them a gap, and for 2-3 months I give them DHEA and CoQ 300 twice daily for at least 2 months, and 1 cycle prior to the stimulation I'm giving testosterone gel from like day 3 till the time she gets her menses, 1 pump per day, as Dr. Anand has stated. And what I find is that the number of oocyte was actually more than the previous stimulation, and the embryos were also better. So I think testosterone gel, especially in elderly age group more than 35 years, it works better. So it
I'd like
does
to
give
just
a better
caution
result.
you about the T transport trial which was
Yes.
published.
Yes,
And
yes.
the T transport trial said that it does not make much of a difference. But try and understand that the dose that was used was just 5.5 milligrams, whereas what Anand said, one activation is 12.5.
12.5.
12.
12.5 we have to
And in
use.
fact, in the Andrew IVF protocol, they
They are
suggest
giving
25
twice.
milligrams.
25.
But 25 is very, very high. And why the T transport trial was carried out with 5.5 milligrams was because patient did not tolerate that much high dose of testosterone. They started having acne and hair growth, and you understand how patients are really not very comfortable using that. So that's why probably the dose was brought down to 5.5 milligrams. But what we have found is with a moderate dose of 12.5 milligrams per day, I think it makes a lot of difference.
Yes, sir.
Okay. So now should we go on to, does dose variation impact response? Dose variation of gonadotropins. Are there some individual patients for whom dose matters and others for whom lowest effective dose should be used? Or should the lowest possible dose be used for all patients? Now we're talking about gonadotropins here. So
Yes.
what are the different...
Dose more than 300 rarely works. I have never used dose more than 300 in these poor responders, because increasing dose more than that hardly works. So that is the maximum dose we are working on. And dose adjustment, of course, if the patient is, here we are talking about poor responder, but if the patient is in the risk of hyper response, then definitely we would like to use a lower dose. But in this group of patients who are poor responders, I think 300 works best.
So the question is very simple. Is there any role of...
Case of FSH polymorphism cases,
Yes.
where if there is FSH receptor polymorphism, then increasing dose might help. But
Yes, you're right.
actually, we have seen going beyond 375 won't help. Maybe you can increase dose by 75 from the previous cycle, or maybe you can add LH in the form of recombinant LH or
Very good.
HMG. And even adding LH might help in increasing FSH receptor sensitivity, and you might recruit more follicles. Because in this case, what we have seen is, despite of giving all this pre-treatment, even in the second cycle, though she came positive because of good quality of embryo, or maybe because of improved lining, but even in the second stimulation, she did
Yeah,
not
yield
get
was poor.
according
Yield
to
was
her
not there.
PSC,
Yes.
and though she
So
was
FOI
on
was less.
group
Yes.
1,
Agreed.
the number of finally retrieved follicles were less only in
Yes.
even the second stimulation. So she might be having a receptor polymorphism where increasing dose slightly and adding LH in the form of HMG might help.
Yeah, so here we had used recombinant LH. We had used Fertilogix, which was recombinant FSH plus LH in the dose of 2:1. So that
Yes.
was taken care of.
What's the
Yes.
cases, the recombinant works better.
Yeah, true. So my question was, whether there is any room for doing mild stimulation in such patients, the poor ovarian responders patients. Is there any role of mild stimulation?
So in
Yes,
coincident group 4, we can prefer mild stimulation, where we know that increasing dose may not help and give more oocytes.
Absolutely.
Yeah.
So where we have only 1 or 2 follicles, their mild stimulation might work better than pumping more gonadotrophins.
Yeah.
So
But
there is also a role of adding letrozole. That also
yes, we
helps
heard
in
about that.
giving.
That is,
Yes,
yeah.
yes,
We have not
yes.
had any
Yes,
experience
yes,
with
we can
addition
add
of letrozole. But
letrozole.
yes, maybe that could
So
be true. The
letrozole
idea
is
is overall with mild stimulation, the response is not as good as we expect. And as Tejas has mentioned, that the number of oocytes is going to be much more if you require as such. So what happens is the cancellation rates are more, and because of the cancellation rates, there is a patient dropout, which nobody can afford to bear as such. So idea is that probably mild stimulation has very, very limited role or absolutely no role at all. So what about long agonist protocol? Is anybody using long agonist protocols for responders? Yes, Anand.
Sir, I have used it. See, I always study the previous cycle. If in the previous cycle we have had more follicles or a very asynchronous growth, like one follicle reached 24, the others are still 16. You have to study the previous follicular chart. That's why previous medical records are so informative for us.
Yes.
So if supposing the fort is not good, so we know the preantral follicle, and it's less than 70%. Ideally fort, that is follicular output rate, should be at least more than 70%. Then I would change the protocol. It's not like you have to use one protocol, you have to do something different. So the agonist protocol, if it's not synchronous, if it's not given a good fort, then I would use an agonist protocol, obviously being mindful about the AMH. If it's too high, then obviously we're not dealing with too high, because we're dealing with poor responders. So agonist protocols give a very synchronous growth for the follicle, and we do a HCG trigger in the end. Then
Protocol just the synchronization. So if we want to use antagonist protocol only, we can do synchronization with pre-treatment estradiol or short OCs, or if we don't want to use long protocol.
Yeah.
So even pre-treatment, 3 days antagonist first, 2-3 days you give antagonist and then start. That is also a good option. That is also, and my first line of manage is always antac if it's a first cycle. Of course, if she has done some cycles outside and come and antac has not worked, you can very well think of long protocol. That is also a very good option.
Yeah.
So here we just summarize as to what Cochrane data says. This is 2010. Dr. Shirajit Bhattacharya's group, which was saying that there were 10 trials comparing 8 different comparisons. Only 1 reported live births. Number of oocytes retrieved were significantly less in the GnRHA long protocol versus the flare protocol versus antagonist protocol. Significantly higher gonadotropin dose used versus when you compare with stop protocol or antagonist protocol. This is in the long protocol, long agonist protocol group. And cycle cancellations were more in the flare group versus the agonist protocol. So anybody using flare protocol?
No, sir, I have not used. No,
Yeah,
sir, just have experience of ultra short protocol in poor responders.
Yeah. Okay, that is different. Yeah, fine. So basically, when you use recombinant FSH, and here we're talking about Recovel, of course, which is not available in India, but this is a paper which has come in the Fertility October 2024. In the group 3 and 4 Poseidon patients undergoing IVF ICSI for IVF, is antagonist protocol the best? And what they had to conclude was, with an antagonist mixed protocol, the duration of stimulation of a recombinant FSH was statistically lower, whereas the number of mature oocytes is statistically higher. The luteal agonist protocol may be used in groups 3 and 4, which we discussed in a short time, some time ago. The group 3 and 4 Poseidon patients without any statistical difference. So if at all you are going to use the luteal agonist protocol, the long protocol, group 3 and 4 would be ideal for this. But again, there is not much difference, and it involves a lot of injections plus a longer duration of stimulation as such. Anybody wants to comment on this?
No.
No.
Okay.
Many other evidences say both are same. So whatever you are
Exactly.
more comfortable with, if we are using antagonist protocol for all, then better we just do synchronization in this poor responder rather than changing our protocol entirely, where the staff may not be trained well.
Absolutely, absolutely. The only advantage of using an ergonomist protocol is getting synchronized cohort, nothing else. So there is no doubt about it.
But my question is, does synchronization assure you of better quality or better number of eggs? That has not been proven.
Better number of oocytes. Better number of oocytes.
Yeah, so but that has not been proven that it is beneficial, or finally what happens is the live birth rate. It has not translated to better live birth rates. So totally whatever we are discussing today, ultimately if it doesn't translate to a great live birth rate, then probably we are dealing with just another additional of thing which in the years to come probably we may say that it is not as good. So let's move on to what are adjuvants to stimulation. Optimal protocol that optimizes the recovery of available oocytes. So we discussed about DHA and CoQ. Let's talk about growth hormone. So growth hormone improves maturation of oocyte cytoplasm and nucleus, promotes granular cell steroidogenesis. Growth hormone acts through IGF-1, which suppresses follicular apoptosis and assists acquisition of FSH responsiveness. In humans, growth hormone promotes maturation of denuded oocytes in the women undergoing IVF treatment, and intrafollicular growth hormone concentrations correlate with chance of conception in IVF cycles. So the rationale for use of growth hormone is to assist the low responder by increasing the recruitment of pre-enteral and enteral follicles and potentially improving embryonic development. And what is the effects of growth hormone? There is significant increase in number of oocytes collected under and less requirement of medications like hormones, improvement in clinical pregnancy rates, but differing conclusions with respect to live birth rates and RCTs. As I was mentioning a few minutes back, that ultimately if it's going to improve the live birth rates and and take home baby rates, it's going to make a lot of difference. But that has not been shown. Growth hormone for an IVF cycle in low responders leads to a decrease in the ovarian stimulation required, collection of an increased number of oocytes, then a similar cycle without growth hormone, and potentially an increased chance of live birth rate. This was Robert Hart in 2022. And another article which has been published in Fertility Study 2024, just using 8 units per day for 3 days from day 2 of stimulation may improve outcomes in terms of oocyte and embryo quality, but not embryo quantity, but not quality. Beneficial effects of growth hormone are limited to aging women, that is women in the group 4 or 2, and the growth hormone and IGF-1 deficiency during senescence is known to happen. So maybe these are the patients probably who will sort of benefit from use of growth hormone. Anybody has experience of using growth hormone?
Sir, I have used in few of my patients, like not many.
Yeah.
Very conclusively, I will not be able to say how much benefit I got out of it, but yes, definitely in the patients I used, I could get blastocyst, so maybe it was working, but we never know because we are working so many things we are giving to the patients. So ultimately, we are not able to say that which worked best.
Yes, and that is very frank, of you, because even I'm going to say whatever is my experience, but that doesn't mean that I've got extremely good results or I can compare with results, because unfortunately today none of us are able to get data on what is the use before, what was the sort of effect before growth hormone and after growth hormone. But yes, we have seen that the number of top quality embryos is much more better when you use growth hormone. And this is the literature which shows we've been using growth hormone for the last almost 5 years and in varying dosages. Initially, we started with using the 0.1 milligram per kg body weight, which was working to around say 66 to 8 units per day. That was working out very expensive for 6 days as such. Subsequently, we changed to 4 units per day as such, which is currently recommended as such. But what we've been using in this earlier patient that we saw was this lattice regime of 2015, which shows that growth hormone in 0.5 international units per day from day 21 of the previous cycle till the time of HCG trigger. And what has been seen is that there is increased top quality embryos, cryopreserved embryos, and excellent clinical pregnancy rates. So this is something which I have been following. And of course, I cannot boast of saying that we have extremely good pregnancy rates as such. But yes, this is something which has given us some kind of satisfaction that we are getting at least top quality embryos. In fact, the last one patient had just one embryo, but really good quality embryo, and she conceived without much problems.
Yes, sir, exactly.
So what is Cochrane database of studies saying? That the conclusion on growth hormone is, again, this is somebody, most of the times, I don't know, Anand, you can probably tell me, how come most Indians are doing this kind of work in the last few days? There was Sandeep Nayak earlier, now Akanksha Sood. All of them have been doing great work. So this is something which has been summarized in 2021, that normal responders, there is uncertain effects on live birth rate and mean number of oocytes retrieved when you use growth hormone. But in poor responders, there's slightly increased number of oocytes retrieved and pregnancy rates, and uncertain effect on live birth rate, which we discussed in the previous cycle. I think then pre-treatment with coenzyme Q, I think we've discussed this enough. Should we go to the next? Okay, what is the size of follicles at trigger you would think about? In poor responders, we're specifically talking about low responders.
So there was a very nice study by Dr. Fatemi, and he had, sorry, ma'am. So he had noticed that, especially in Poseidon group 4, don't wait, to give the trigger, beyond 18 millimeters. 18 millimeters in a Poseidon group 4, don't wait too long, because you will risk losing, their LH surge can be quite quick, and we'll risk losing the egg. So, and the older age group patients, the maturity of the oocyte also happens fairly quickly. If you see, even the follicular growth also happens very quickly. So Poseidon group 4, 18 millimeters was the cutoff that he had said. Sometimes we go till 20 millimeters. Obviously, it's a cohort, so we want, all of them.
I think usually in all the patients we would do this, right?
But dual trigger. We'll give a dual trigger and
dual trigger. Yeah.
So I think most of us are synonymous in thinking that dual trigger is the final thing for today, especially for poor responders. No question about it.
Probably a normal hypo responder. Maybe at 17 mm is a good time, and we did not hit 18 to 20 mm.
18 to 20 is a good this thing.
Agree. No question about it.
Don't go beyond 24 millimeters. Yeah, the follicle which reaches beyond 24 millimeters, the oocyte quality degrades. Yeah.
Yes, agree.
Definitely.
So here I'd just like to draw your attention to this publication in the USG Obstetric Gynec 2018 journal, where data from IVFM studies showed that follicles which are 4 millimeters also can contain mature oocytes. Follicles less than 10 millimeters with HCG priming associated with fertility outcomes are similar to those of larger follicles. So just try and understand this. The rate of oocyte recovery from small follicles, which are just between 8 to 12 millimeters, is definitely lower than medium-sized follicles between 13 and 23 or 24, more than 24 millimeters. But both fertilization and blastocyst rates for M2 oocytes derived from any of this is not significantly different. But you do get M2 oocytes from 8 to 12 millimeter follicles. The live birth rates is higher in pregnancies arising from smaller follicles versus medium and large follicles. And this is the figures that they have quoted. So therefore, we need not think that below 10 millimeters or below 14 millimeters, we should not aspirate. The implication is that smaller follicles should be aspirated and used. The only thing which I would like to draw your attention to is this Japanese study from Reproductive Medicine Biology 2021, which shows that oocytes from smaller follicles, the fertilizations are lower with IVF, but with XC, the development potential to blastocyst of oocytes from small follicles is similar to that of oocytes from larger follicles. So therefore, do not neglect the smaller follicles. And as Anand was talking about rightly about the trigger, the time in trigger, as such, we know for sure that delaying the trigger does not help. It has been shown very clearly. So therefore, once you decide that the follicles are mature, going ahead with the trigger and going ahead with oocyte retrieval is most important. I think we have concluded on the dual trigger. We did not discuss more on this. Yes. The technique of oocyte pickup, does anybody use dual lumen and rinsing of the follicles? This is to
So
optimize the
even the
number of
follicular flushing is not something that is recommended by any of the Cochrane studies. They did not find any significant difference in the number of oocytes. But whatever, like I said, there is something called as evidence-based medicines and there is something called as experience. And these are like always, these are desperate measures. So I do flush using a dual lumen when we have only 2 or 3 total follicles. Just, I mean, it's not going to do any harm to the patient. It's not going to, like, 2 or 3 follicles flushing will not increase the anesthesia time. Also, it's a practical decision, what I would like to put in from my perspective. That yeah, if it is just 2 or 3 follicles together on both the sides, she's a really very poor responder. There is no harm in doing a follicular flushing 2 times, maybe using a dual lumen. But otherwise, evidence, if you ask me, there is no significant difference, and it is not recommended to do regular routine flushing for all poor responders.
So I have somebody who has mentioned very clearly in this presentation in the ESHRE conference 2024, where they were flushing for all patients and they have had a 10% more rate of retrieval in such patients. But in poor responders, as Sridevi rightly said, that we would probably do it in patients where you expect a very low output as such, and to not leave away any kind of oocyte
Even
complexes.
take the smallest possible follicle, just don't leave anything.
Exactly.
But in UK, they would regularly they were doing flushing for all patients, not just poor responders. My training was all, and it really increases the time. It does increases the time of the procedure. But yes, there are sometimes in the second flush, third flush also you get an oocyte, and that's an extra oocyte. But I don't follow it here. I just do a single lumen. Yeah.
Okay. I think Tejas, I'll stop here because this is endless. So I think we'll continue with the second case.
So I think you've stopped sharing, sir.
Yes.
I think we're running out of time. I'll just take it.
Yeah, go ahead.
Yes, Dr. Aditi, Dr. Ditya.
Are we done?
Yeah, Rishikesh. Do we have 10 minutes? Maybe we can just wrap up by 7:30 if they want, maybe
Yes,
one.
yes, definitely.
Yeah, I think because
No
the
issues.
discussion is interesting, and if time permits, let's continue.
No issues, madam. Time is there with
Okay.
us. Yeah.
Okay. Thank
So
you.
I think
We
we'll
can
take
continue.
only 5 minutes. A lot of the discussion is already. Sorry.
Yeah, regarding the last thing, meanwhile, till you open the PPT again, if we are seeing 3 follicles on ultrasound, and if we already got 3, there is no point of doing flushing. If we are seeing 6 follicles and we got only 3, and output is less, then only there is a meaning of doing
Of course,
flushing.
after seeing the first ovary, if you feel that the yield is less, yeah, that is a yeah, that is of course, yeah, yes, definitely.
So I think we have discussed a lot of things regarding pre-stimulation, what needs to be done. I'll just have a discussion regarding polymorphism, a little bit of discussion regarding polymorphism. I think somebody was saying that we need to do a polymorphism testing, and then we may increase the dose or something. So has any of the panelists ever done a polymorphism testing? And what is their experience, or do they think it is actually helpful?
We don't do
Not
testing, we just simply increase the dose so that if at all there is recursive polymorphism or less sensitivity, it can be taken care of.
Okay, correct. Anybody else?
no experience. I have not.
No.
Correct. So I think a lot of times we've been speaking about polymorphism and the concept of polymorphism whenever it comes to patients with poor ovarian response. But I think let's understand this, that polymorphism testing does not change the management. Why doesn't it change the management is because, say, for example, if you have a patient who's had a poor response, you are anyways probably going to increase the dose from the preceding cycle, or you're going to add LH in the stimulation protocol. So at this moment of time, we are not at a stage where polymorphism testing is changing the management as such of our stimulation protocols. So, I just wanted to highlight a few things that these are the polymorphisms, like FSH polymorphisms, LH receptor polymorphisms are the ones that are commonly being done. This was the study that was done in our department when I was in Chennai. And what we found out was it did not make a difference, these polymorphisms. Testing these polymorphisms, it did not change the management as such. Now, next thing is the patient that we spoke about, the case one that Sir discussed. I think, can anybody tell me what Poseidon group does that patient belong to?
Poseidon 1.
Was
Correct, correct. So
Different
basically, she's Poseidon 1A. She's Poseidon 1A.
one.
She's
A.
young. Her reserve is normal. AMH was more than 1.1. Antral follicle count was more than 5 to 7. And she belongs to 1A1, correct? So now, ideally, in these kind of patients, whenever you are looking about the treatment strategies to improve your outcomes, in these patients, if you can see on the left side of your screen, the only options that you have is change the gonadotropins. That's it. Because in these patients, oocyte number is already there. 5 to 6 oocytes are already there. So giving them pre-treatment for 2 months or 3 months is probably not going to be helpful. I hope all of you agree with
Yeah.
this, that giving 2 3 months of treatment is not going to be helpful for them. In the case that was shared by Dr. Rajkumar sir, I think the only thing I would have done differently is probably give a lesser dose on day 9 and day 10. Because on day 10, the follicle size was already 21 and something like that. So probably giving a lesser dose on that day, maybe because if there were almost 8 to 9 follicles and they ended up with 3 follicles.
The
Sir, what
oocytes.
is your opinion? Means that's what I feel, that probably giving lesser dose, not the same dose, because the follicle size was already 21 and all that on that day, last day.
I think so.
So, so now this is the similar case. The only thing is we are dealing with an older female, which is more than 35 years of age, and she is married for 5 years. Husband is fine.
Tejas, we can't see your screen.
Because your slides are
We
not.
cannot see the case.
The case is not.
But my screen sharing is good.
Tejas sir, I'll request you to please be on the slideshow mode.
Start the
I
slideshow mode.
yeah. No,
No.
that must be a technical challenge. Saying what?
Now my screen is seen.
Yeah, but the
Yes.
screen is seen, but
The
they are not on the
slides
slideshow
are
mode.
not moving.
Now it is seen.
No, still it is on the normal mode. Slides are visible, but they can't. They'll not be moving then.
Now
Now it's okay.
Okay. So I think let's take this female. She's older female, more than 36 years. She's 36 years of age. Married life of 5 years. Similar to failed IUI cycles. On infertility workup, AMH is 0.9. Antral follicle count is 4 to 5. Now, how would you like to? And this patient is planned for IVF. So I think we've already discussed about androgen supplementation. I just wanted to show this slide where we are talking about increasing the egg number. Whenever we're talking about increasing the egg number, if you can see in this slide, moving from a primary follicle to secondary follicle, it takes approximately more than 120 days. From the secondary follicle to antral follicle, it will take around 71 days. And from antral follicle, all of us know till the dominant follicle, approximately 14 days. So your androgen supplementation should be there for a good period of time. If you really want to increase the egg numbers. So if you check here from the primary follicle till the antral follicle, it is taking almost 190 days. But none of us will supplement a patient for 190 days. Probably practically it is not possible to supplement a patient for 190 days androgen supplementation. So that's one of the most important points whenever we are talking about a diminished ovarian reserve patient, where you are trying to give supplementation with androgens and trying to see if egg number improves. But none of us are doing it for a long period of time to actually have an impact on the egg number. So only the only part that remains to be discussed is the rejuvenation strategy. Anybody has experience regarding PRPs and stem cells, they can voice their opinion.
I have been giving PRP to the patients, and we have recently started using stem cell also. So, actually, to be very honest, like one
So,
of
ma'am,
the of
PRP,
stem
PRP, when do you do? When do you do PRP?
PRP, like we do in the first, like after menses, within first 5 days before the dominant follicle comes up. At that time, I am giving PRP. So it can be I'm giving two ways. Either I sometimes I give by ultrasound guided, or if the patient is having some other indication for laparoscopy, suppose hydrosalpingo or something, or I have to tell any other reason, then I
That's
give by
fine. So
laparoscopy also.
basically,
Otherwise, by ultrasound
just to
guided, I am
understand,
giving
when
the
do you
patient.
do it? When do you do it? You do it prior to stimulation, you do it at the time of oocyte
At
release.
least two
When do
months
you do it?
prior to the stimulation. At least 2 months
2
prior to the
months prior.
stimulation.
2 months prior.
Yeah.
Okay.
Yes.
So,
And
there is a study published by
And
Firuza Parekh in the
how has
Fertilogix.
been your how
yeah, see, I have actually a mixed experience, I would like to say. Like, in some
opinion?
of my patient, I do have got good embryo, and in one of my patient, I remember I got only one oocyte, and that resulted in one embryo, 3/8 cell, and she conceived and healthy baby delivered. In some of the patients, I have not got result, but basically, what I notice is the patient, if the choice of the patient is very important. If I choose patients who are like more than 40 years, 39, 40 years, 41 years. In those patients, it's not actually working.
Yeah.
So it's more younger group of patient with the AMH also, if very low, that I'm not getting a very good response. But somehow, somewhere if the AMH is between 0.5 to 1.2, like that, in those group of patient with age between 35 to 38, those group of patients, still I'm getting results. But if the AMH is too low or the age is more, then I'm not getting a response. So likewise, I counsel my patient also that if it's a low prognosis, like not a good response patient, then I tell them, see, this is the chances. But sometimes the patient do opt that they still want to go ahead with PRP. Then I do, but I'm not very happy with the results in those group of patients.
I think in older age group patient, I've tried it on two patients, who did not want to go for donor cycle because of
Yes.
cultural reasons. The last resort, one was 42, one was 44. It really did not work.
It doesn't work. It
It
doesn't
doesn't
work.
work.
But
FSH,
laparoscopically also, I have given in older group of patients. Sometimes the patient will come, no, I want to try with my own. Laparoscopically, they are ready. They have given because laparoscopy are like you can give more properly, like in ultrasound guided, because the ovaries are so small. Sometimes you're not very sure whether the PRP is proper place or not. So laparoscopy guided also I have given in older patient. I'm not getting good result. So
those
I
with a
think
day
young.
2 FSH of more than 8 also don't respond well.
Don't, yes, yes, yes,
And
yes.
there are some studies, I would say, that multiple in younger patients also, sometimes not just one seating, multiple seatings are required. But then do we have, I mean, that's a decision we have to take. How many procedures do the patient
How
undergo?
many
Does the
procedures
patient
subjecting
undergo?
the patient again and again?
Yeah.
That
So
So to answer Tejas's question, about when to instill the PRP, Firoza has published a study where in the previous cycle of home pickup, post pickup, immediately she would do the PRP injection and then subject the patient for subsequent, stimulation and things as next cycle as such. Maybe not next cycle after 2 months. I'm not very sure about it. But the time of injection would be at the pickup time when she does in the previous cycle. And this has been published.
I follow the
Yes,
same
yes.
thing where
Some of my friends are also doing this, that they are giving at the time of home pickup.
correct. So I do the same thing
I think
where
there is no standardization on PRP and stem cell, when to give, how much
Still
dose to give,
experiment.
after
Still
how many
experiment.
months to do the stimulation. There are so many unanswered questions, and I think everyone is doing the way they are comfortable with.
Yeah.
So
2%.
there is no standardization on this
Yeah,
PRP
correct.
and hormone
There
stem
is
cells.
lack of standardization. There's lack of concept, I think, because we again the same thing that what are we trying to achieve? Are we trying to improve the egg quality, or are we trying to have more number of follicles at the start of stimulation?
Yes,
So
yes.
I think there is confusion regarding this. But even I have the same opinion as Dr. Kanchan that I keep doing it for patients with diminished ovarian reserve, and I do it at the time of oocyte pickup. There are patients where things have been better. There are patients where things have been the same. It has not made a difference. So, and plus, it is also important to understand that whichever PRP protocols that you're using, are we able to achieve a therapeutic platelet levels in it? We normally say that therapeutic platelet levels would be 10 lakh per millimeter cube. So, approximately 10 times what is there in the blood is what you want to achieve, are the therapeutic platelet levels. So I think there are a lot of variations and a lot of not so clear things are there when it comes to PRP and using stem cells. But nevertheless, I think that it will be given as an option to all the patients who want to have want to try with their own gametes. So I think this can definitely be tried for patients. So I think
Here, like our first stem cell patient, after that we did IVF and the patient conceived. And my second stem cell patient, she conceived naturally. And
so,
after
but
that, I did two more, but
in stem cells, where are you getting the stem cells from? Are
from
these
the
mesos
iliac crest. From the iliac crest,
iliac crest?
yeah,
Okay.
yeah.
And then, are you running it as a research protocol, or how do you do it? Do you
So
do
fresh,
you
like we collect at the same time we take from the iliac crest, the patient stays in the observation room, we prepare immediately. For that, you don't need any licensing or like that. If you're doing freshly, like you immediately we take it to the lab, we process it, we separate the stem cells, and we immediately then we put the patient for the laparoscopy, and we inject by laparoscopy. So if you're doing that, you don't need any licensing or any any other this thing for that. So.
correct?
That's how we are doing it.
Nice. Okay, I think we can close the panel discussion. Dr. Aditi.
I
It
think
was a very nice panel discussion.
Yes,
Thank you, Dr.
thank
Tejas.
you, sir.
Dr.
Thank you, Dr. Tejas.
Thank you
Very
so much.
nice. We actually we learned a lot and from everyone's experience, and it was
Yes.
wonderful being a part of it.
It was
Yeah, thank you, everybody. And thank you, Madam Archana, for having us, me and Tejas, and for moderating this. Thanks all my panelists for having been sort of putting up with us for such a long sequence of the panel discussion. But I hope at the end of the day, somebody or everybody has benefited from it. Thank you
Yes,
very much.
absolutely.
Thank you. Thank you,
Thank
Dr.
you,
Shah.
madam.
Thank you, Archana ma'am.
And
Thank you.
thank you, Tejas. And I would like to extend my thanks to all the panelists for their active participation and their inputs in this panel discussion. I learned a lot. That's very important that you learn from each one and everyone. So, and thank you to my coordinators, Dr. Garima, Dr. Aditi, Dr. Amrita, and Dr. Ditya, and UNS for providing us this platform. So thank you,
Yeah.
and we meet again at some point of time, right? And look forward to seeing you in person sometime soon.
Thank you. Thank you, everybody.
Right,
Thank you.
right.
ma'am.
Ma'am, thank you very much. With your due permission, I would like to give a final vote of thanks on behalf of
Yes, yes,
UNS.
Rishikesh. Yes,
Yes,
Rishikesh, go on.
just for a second, madam. So, thank you everyone. On behalf of Universal NutriScience, I extend my heartfelt gratitude to all esteemed chief guests, guest of honor, speakers, panelists, and chairperson for sharing their valuable insights in today's Inspire webinar on POR, that is Poor Ovarian Responders. Special thanks to definitely Archana Madam, MPSR, and all our MOCs and conveners for their collaboration and support for making this event initiative possible. And most importantly, I sincerely thank all our participants who are joining for this evening and making this session truly engaging. With this, I'd like to conclude today's webinar and looking forward for welcoming you again in the upcoming editions of Inspire. So thank you everyone. Have a great evening ahead. Thank you. Thank you.
Thank you,
Bye-bye.
Rishikesh. Let's
Bye.
bye everybody.
Bye-bye.
Enjoy the rains and Ganpati festival in Mumbai.
Yes, ma'am.
And
Yes.
all the best, madam.
Thank you.
Right.
Yes,
We
thank you, Amrita, for being so proactive. Thanks a lot.
Thank you.
Okay. Thank you
you, ma'am.
everyone.
Thank
Thank
you.
you. Thanks Shruti. Thanks Sanskriti. Thank
thank
you
you.
Archana
Thank you
ma'am.
to all doctors.
Thanks
Bye-bye.
everyone. Bye-bye. Anand Kishore, please call off the Zoom meeting. Bye. Bye. श्रुति श्रुति आप पहुंच गए घर पे?
नहीं नहीं, मेरे को यहाँ